in for the meeting. We've all tested our audio and video. We're all good. So it's 5 o'clock, and I'd like to call the meeting of the Knox County Board of Health to order. And as a first order of business, we're going to have a roll call. So Narda, are you with us today? Are you doing the roll call?
That would be me.
Martha, good to see you. Okay, roll call time.
So, Dr. Drake.
Present.
Dr. Gocher.
Here.
Dr. Hurt.
Here.
Mayor Jacobs. I believe you're muted, Mayor Jacobs.
Sorry about that. Here.
Dr. Shamia.
Here.
Dr. Souza.
Here.
Ms. Wagner.
Present.
And I'm here too. So
Great. So we have
Dr.
everyone.
O'Brien. I'm sorry, Dr. O'Brien. I skipped his name because I didn't see his face.
And Dr. Greg is also with us today as a guest speaker.
Correct.
And so we do have a quorum because we've got everyone save one here. So having established that quorum, the next order of business is the public forum. And I understand that my task in the public forum is going to be to watch the clock and let our speakers know that their time has expired, and then we'll have, I guess, a little bit of time to prepare for the next speaker. And I'm looking at the image of the meeting place, and I don't see anyone there. Is there anybody present, or is there anybody ready to speak?
I'm present.
Dr. Gocher, I believe, is that Charlotte Meyer? Please come on forward if that's who you are.
Like her.
Very good.
Good like it is.
Very good. Welcome.
Hello, my name is Charlotte Meyer. Can y'all hear me all right?
We certainly can.
Okay. All right. I'm here today to talk about the public library computers and us being able to get some of those open back up for use, especially now that the Governor Lee has placed an order again for all work search on anybody that's on unemployment right now. He's putting that into effect this month in September. And so it's pretty imperative now that people be allowed to access the public computers when they don't have one at home or even a cell phone that has internet access. And so I would like to lobby on behalf of everybody in the county for that purpose, that we be allowed to bring up some of those computers. Again, you can get 4 or 5 of them up at one time in each library to start with and space them apart. Like you can have one up, then 2 chairs empty, and then another one up, and then 2 chairs empty like that to start with. And Sevier County Library, by the way, they've had their computers up since June. And right now, I spoke with them again today. They now have 9 computers up and using, and they've got them all spaced out. And what they do is they sanitize real often in between uses, you know, like wiping Lysol wipes on the keyboards, and they keep hand sanitizer nearby and ask everybody to use hand sanitizer on their hands before they sit down at the keyboards and type on the keyboards. And it's working real well there. And other states like Arizona and Nevada also have been using some of theirs as well in their libraries, because I vacationed in June, and both Arizona and Nevada, they were using some of their computers, their public computers in the library. So, and also I called the library in Nashville today to see what they were doing. And right now they're in the middle of working out the logistics so they can get their computers up next week. So I just would like to request that you all consider that, and that we can open this up in a very responsible way and safe way and get some computer access for the public again. Thank you very much.
Thank you very much.
All right, up next we have Mr. Bill Watts. I think he's also joining us from the City County building.
Thank you.
Very good.
Thank you, Mayor Glenn Jacobs, for giving the public a forum. I had hoped that the governor's orders would be lifted and that meetings would be held in public again by now. Last year, I attended quite a few meetings of the KUB board and would like to think that I had a part in getting the basic service fees discontinued for the next 3-year budget period, saving the Knoxville citizens $8 million collectively for the next 3 years. So I do believe in participating and having the opportunity to participate in policy making meetings in our community. I was born next Tuesday, September 7th, will be my 60th birthday. I happen to have been born at the Baptist Hospital just on the other side of the river. As fate would have it, my father died at the Baptist Hospital in the year 2000 when I was 40 years old, and he had been suffering from cancer, and he contracted a pneumococcal virus, and which turned into meningitis and took his life quickly. What I'm trying to understand as a member of the community is how this virus is different from what viruses have always been in the past that unfortunately target the most vulnerable members of our society. And then with the variables of how what type of test is used to determine whether it's a COVID virus and whether or not it is the main factor or a underlying factor. Those are concerns that I have. I would request that the Knox County Health Department provide information to the public in that regard, so that the public can see what causes of death are occurring and what part the COVID-19 virus plays in those deaths according to the death certificate for each death that has occurred and each death that will occur that is attributed, related, linked, connected to the COVID-19 virus. Please make that information readily available to the public so that they can understand what's going on with this virus in relation to what has happened in the past.
Thank you. Are there any other speakers before us?
Yes, up next we have Zach Neighbors. He's joining us via Zoom.
Okay.
Good evening. My name is Zachary Neighbors. I would like to say thank you to the board and both mayors for giving me the opportunity to speak tonight. The two things I would like to see us push forward or move forward with would be legislation helping us to revoke the mask mandate in public spaces, small businesses, publicly owned businesses, and also the private schools and public schools. We have been going through this for 6 months now. We had 7 weeks of a full lockdown countywide. There are 59 total deaths to date, 7,000 roughly active cases, or 7,000 roughly total cases. 5,000 of those have recovered, 2,500 are active. Throughout this 6 months, we've had 269 hospitalized and 48 currently hospitalized. But we also have roughly 500,000 people that live in this county that have to wake up tomorrow with a purpose, with a job, with commitments, not only to themselves, but to their communities and also to our children. I do not have a child myself, but it pains me to think of a child sitting there 8 hours a day wearing a mask, and the only opportunity they can take it off is to drink water and for a lunch break. Through this time, I believe the people of Knox County, the businesses, and also the schools have adapted to this ever-changing environment. We have given everyone the opportunity to go online. You can buy all of your basic necessities online through Amazon or Walmart. All the schools have gone online as far as allowing children to have Chromebooks, access to virtual schooling. So all I ask is, now that we have those options for people who feel they are more protected in their homes, why can we not allow the people in the public spaces to take the individual responsibility at the employer level, the employee level, and also the patron level to choose whether they do or do not want to wear a mask? I believe we're forcing the employees to play the role of cop when it comes to enforcing the mask rules and regulations. And I do not think that is fair to the employees. And it does not make sense to me when you walk into a restaurant wearing a mask to then walk to a table to take that mask off, and then violating all the recommended World Health Organization and CDC guidelines of properly putting a mask on and off your face. I think the people of Knox County have banded together. I think regardless of what side our political views are, I think we need to replace any hate and content in our hearts with love and choose to have conversations as opposed to having arguments. And I would just like to see the board, the mayors, move forward with a positive message and a positive, I guess, just legislation to help revoke some of these mask mandates. Thank y'all, and y'all have a great night.
All right, thank you. Up next, we have Kevin Hill, who is joining us via Zoom.
Mr. Hill, before you get started, I just want to make note, I'm the note taker this evening, so I'm listening, but I'm also taking notes for the meeting. So I apologize if I look like I'm not paying attention. I really am.
Understood. Kerry Mullis is the inventor of the PCR technique, and in an article about HIV, because he passed last August and is unable to speak about COVID, he states, "These tests cannot detect free infectious viruses at all. They can only detect proteins that are believed in some cases wrongly to be the unique HIV." Excuse me, I was just informed that I was muted by the host. Hello?
Sorry, it was an accident.
Okay, can we restart my time so that I have my full time since I'd interrupted it?
Can we do that? Can we go ahead and handle that and restart the timer, please?
Thank you very much.
There you
Okay.
go.
Thank you. Kerry Mullis, the inventor of the PCR technique, has stated in an article regarding HIV, "These tests cannot detect free infectious viruses at all. They can only detect proteins that are believed in some cases wrongly to be unique to HIV. These tests can detect genetic sequences of viruses, but not viruses themselves." We do not have the benefit of Mullis speaking to the use of PCR as a diagnostic tool for COVID, but we do have the benefit of his generalized statements about viruses and the opinions of his colleagues that have worked with him. Reuters fact check discredits the claim that Mullis said his tool cannot be used as a diagnostic test. That is because the quote used by some is wrongly attributed to Mullis. However, Reuters ignores the quotes Mullis and his colleagues have made challenging the use of PCR as a diagnostic tool. David Crow, an associate of Mullis in the AIDS HIV fight, has stated, "Kerry did not invent a test. He invented a very powerful manufacturing technique that is being used. What are the best applications for PCR? Not medical diagnostics." He knew that and always said that. When asked his opinion of the PCR as a COVID test, Crow stated, it is as good as the Scientology test that detects your personality and then tells you to give a lot of money to Scientology. The only difference here, this is my words, is this test tells the federal government to give another $166,000 from the CARES Act to a Tennessee hospital. Yet here we see that against the better judgment of Mullis, who won the Nobel Prize for the PCR technology, the world is using his process as a diagnostic tool. We do know that the PCR is a process dependent on amplification of the genetic sequences. And if the amplification is too low, no one will test positive. And if it is too high, then everyone might test positive. This is a test that currently has no universal standard for amplification. Furthermore, according to Koch's postulate, you must have a purified virus to attribute it as the cause for a set of symptoms. As to date, there is no record of purification of the SARS-CoV-2 virus by any researcher in the world. And when asked about this fact, an author from each of the relevant studies has admitted they do not have truly purified samples. Therefore, the use of a questionable testing method is all the more questionable because it has no gold standard to be measured against. There has been much said about the scientific standards of this board. Please explain why you reject the opinion of the Nobel Prize winning inventor of the PCR technology and depend on an unscientific process to jeopardize the economy of Knox County. We haven't even discussed the fact that now we've demonstrated a 73% better success rate and fatality rates in countries that use hydroxychloroquine versus countries where our medical establishment refuses to allow that treatment to be widely distributed to the citizens. That's another question worth explaining, why we have no local, independent, free of the politicized entities studied by doctors on the relevant data there. Thank you for your time.
All right, up next, we have Brian Bonnyman, also joining us via Zoom.
Hello, my name is Brian Bonnyman. I'm a Knox County native and a family doctor. Since March, I have supervised a local coronavirus tent testing program. My staff and I have tested thousands of people in both broiling heat and numbing cold. We've talked on the phone with hundreds of people who have tested positive, up to 30 in one day. This is a logbook of their names and dates. This is the second logbook I've had since the testing started. If you could see what I see and hear what I hear, you would not only support a mask mandate, but be grateful for it. We listen to tragic stories every day. A few months ago, I called a young wife in her 20s to inform her of her positive result. She was actually at the hospital with her COVID positive husband. She was distraught and had to hang up suddenly because the staff was putting him on a breathing machine. Another positive patient unknowingly spread the virus to multiple members of his family, resulting in the death of an elderly relative. I recently had to call a school teacher in her 70s with positive results. She had gone back to her second grade classroom this fall to be there for the kids, and she now faces a very uncertain future. I know of church pastors who accidentally spread the virus to their flocks, in one case infecting over half the congregation. In one nerve-wracking week at my practice, 3 young coworkers were diagnosed. We braced for the worst, anxiously expecting a major outbreak. I then saw the wondrous effect of mask compliance. The viral spread in the workplace ended when we absolutely required all staff to properly wear a mask at all times, even to the point of eating their lunches separately. I encourage everyone in our community to wear a mask the right way. Not only does proper mask wearing protect loved ones, teachers, our greatest generation, and yes, our healthcare workers, but wearing masks also gives us more freedom so we can get out and do more things. As I near the end of my speaking time as a family doctor, I can't help but encourage folks to prepare for flu season by getting a flu shot to lessen the impact flu and coronavirus together will have on our overtaxed medical system this fall and winter. I also invite medical colleagues and coronavirus patients alike to share their stories in public settings like this so people hear the truth about this illness in our community. I will end with one question for the board. Where online can the public access reliable data on local coronavirus test positivity rates? Thank you for listening, and thank you to the board for your service to our community.
Thank you.
All right, next we have Ms. Purvis also joining us on Zoom.
Hello, my name is Aya Purvis. I'm a homeschooling mom, and me and my son, we've been at home for 6 months, and finally, right now, Dean Hill Recreational Center is starting physical education classes, and we're very happy to join, but they require masks for kids, and he is almost 6 years old, and I don't want him to suffocate or have a lung collapse while exercising. I do not understand why people who are exercising needs to have a mask, and he's very, very young. So I would like to reconsider masks wearing while doing physical education, and for kids especially. Thank you.
Thank you.
Thank you.
All right, next we have Elizabeth Murphy also joining on Zoom.
Hey group. On January 28th, Dr. Fauci said, in all the history of respiratory-borne illnesses of any type, asymptomatic transitions have never been the driver of any outbreak. I dug into the literature concerning face masks and was shocked when I read Neil Orr's study published in 1981. Dr. Orr was a surgeon at the Severagals Surgical Unit. The surgeons and staff there decided to see what would happen if they did not wear masks during surgeries. They wore no masks for 6 months and compared the rate of surgical wound infections from March through August of 1980 with the rate of wound infections from March through August of the previous 4 years. They discovered to their amazement that when no one wore masks during surgeries, the rate of wound infections was less than half of what it was when everyone wore a mask. Their conclusion, it would appear that minimum contamination can best be achieved by not wearing a mask at all, and that wearing a mask during surgery is a standard procedure that could be abandoned. Amazed by this, I dug in further, and it became clear that the studies conducted in the past 45 years have been consistent. Masks are useless in preventing the spread of disease, and if anything, they are unsanitary objects that themselves spread bacteria and viruses. Ritter, in 1975, found that the wearing of a surgical face mask had no effect upon the overall operating room environmental contamination. A review by Skinner in 2001 concluded that the evidence for discontinuing the use of surgical face masks would appear to be stronger than the evidence available to support their continued use. Bali did a systemic literature review in 2009 and found that no significant difference in the incidence of post-operative wound infections were observed between masked groups and unmasked groups. Dazhou et al., reviewing literature in 2015, concluded that there is a lack of substantial evidence to support claims that face masks protect either the patient or surgeon from infectious contamination. I could keep going, but I think you get the idea. With the knowledge that asymptomatic spread is virtually non-existent and that there are decades of peer-reviewed studies showing that wearing a mask is nothing more than a placebo effect on the public to feel safe, why do we have Dr. Buchanan saying yesterday that we'll be wearing face masks for the next 6 months? I assume she means that this board will mandate masks until a vaccine is ready, completely disregarding that no RNA vaccine has ever been successfully and safely developed. No animal studies are being done, and the manufacturer of the eventual COVID vaccine will be legally immune to any injury or death. I beseech anyone here who is listening to take off your mask and never put it on again. This board has no power over you. We are sovereign beings. If there truly was a pandemic, then no face mask mandate would be necessary. Folks would be fearful enough to wear one if they so chose. Instead, this board has shown that they have chosen to use their unelected position of power as a way to control the public at large. They have bought into shoddy science and an agenda I can only speculate on. Having a curfew is about control, not safety. It may pigeonhole me as a conspiracy theorist to mention Agenda 2030, but we are seeing it play out in front of our eyes. This board has overstepped numerous boundaries, and I'm here to ask you tonight to undo what you have done. We are watching, and there are more of us watching every day. We will not be silent, and we're not obeying.
Next is Chrissy Stevens, also joining via Zoom.
Hi, my name is Chrissy Stevens. Thank you for this opportunity to speak to you all. I'm here as a representative of the people across this county that for religious, medical, physiological, and psychological reasons should not, cannot, and will not be masked. I do not wear a mask, not because I'm anti-science, not because I'm uncaring to others, not because I'm better or smarter than others, and not because I think the COVID virus isn't real. I do not believe that I'm above the law or mandate in this case. I believe that I am and should be protected by established laws. I'm blessed to be a citizen of this county, this state, and this country, and as such, I have rights and civil liberties afforded to me by many laws, such as the Civil Rights Act of 1964, Section 201, the ADA, and Tennessee Code Section 4-1-407. Those laws and others protect citizens' rights to not be discriminated against for multiple reasons that include, but are not limited to, race, color, age, gender, sexual orientation, religion, medical disabilities, and the like. A business owner cannot make store or company policy that violates established law. For example, if a business owner decided to deny entry or service to people with red hair and posted signs on the door that read no redheads allowed, that doesn't make that policy legal. Privately owned and corporately owned business establishments that are open to the public must, by law, make public accommodations. Even establishments located on private property must adhere to this rule of law. A state of emergency or a local or national pandemic cannot suspend established law. You have encouraged and emboldened business owners in this community to deny civil liberties to those who do not mask. Even worse, the public is sometimes met with an employee asking you to take temperatures and ask medical questions regarding exposure to COVID. This is illegal, as a clerk or manager is not a licensed medical professional. It is illegal to give medical advice or practice medicine without a license. It is, however, legal for me not to agree to any unwanted medical procedures or answer any medical questions from anyone, especially someone that is not my doctor. Dr. Buchanan, stated in the August 19th board meeting that Corona is not going away and that we are all going to be practicing the 5 core actions for many, many, many months. What exactly is the board's plan to lift or rescind Regulation 2020-1? What exactly is your end goal? According to your website and data updated as of 8/25, of the 5 benchmarks listed as criteria for reopening, 4 are green lights. I ask that the board lay out a clear plan to Knox County citizens as to when and how the mask mandate will end. It is time to get Knoxville back to normal and let citizens rebuild and recover. With the passage of Regulation 2020-1, you have created an environment of fear and discrimination in this community. You have crippled and destroyed businesses and eliminated jobs and livelihoods, the likes to which I have never seen before. I urge the board members to rescind Regulation 2020-1, and if that is not done, to denounce denying services to those that cannot, should not, and will not be masked. Thank you for your time.
Thank you.
Next, we have Mark Whitmire joining us on the phone. Mute yourself.
Mr. Whitmire, if you can hear us, if you unmute your phone so that you may speak.
Jimmy said I'll try to call him. Okay, well, we will move on, and just in case we can get that one back on the call here in a little bit. Next is Michael Murphy, also joining us on the phone.
This is Maria. It looks like they're muted. So they may be trying to talk.
Yeah, exactly. They are muted, so we're trying to ask them to unmute. So again, Mr. Murphy, if you can hear me, please unmute your phone so that you may speak.
Oh, he's coming back in.
Mr. Whitmire, it appears you came back in. If you could unmute your phone so that you may speak. Okay, so Catherine, I think.
All right, what we can do now, since we can't get them on the phone, we can try to reach out to them separately and see if we can't get them back on. And in the meantime, if the board wants to move forward, perhaps if we're able to make that work, we can interject and bring them back on. If that, Mr. Sanders, if that causes any problems, please let us know.
No, it's your meeting. You can bring them in when you want to. If you want to be technical about it, I guess you're going to amend your agenda, but you also already have, I believe, a point at the end of your agenda for public forum, so you can just move them to the end of the agenda.
Can y'all hear me now?
Yes.
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 Sorry, I don't know what's going on. I hit *6 and nothing.
Sorry about that.
Okay, may I proceed?
You may. Can you please tell us who you are for sure?
Oh, Michael Murphy.
Oh, okay. Thank you.
Okay. Just thank you for allowing me to talk tonight, and good evening to everybody. You know, in the beginning of this pandemic, or whatever you want to call it, we were told by the CDC that masks would do more harm than good. And then even the U.S. Surgeon General stated that the data doesn't back up using the mask. And when I bought a box of masks, it even says on the side of the box, will not prevent coronavirus. And I'm just, you know, I've been quietly just watching. I try not to watch the news media because I found it real quick that they're presenting a slanted message. And so I went to alternative media and then talked to different doctors. And apparently, I apologize if I repeat information that you already know, because I know that you all been deluged with a lot of information. But this pathogen is even less deadly than the flu virus and the SARS virus, and apparently it's got a death rate of 0.044%. I rounded it up because the actual number is 0.0039%. And I agree that even one death is too much, but the shutdown of the world's largest economy on a pathogen that's got a very, very minuscule death rate is just boggling to me. And to shut down small businesses and mom and pop operations and shut down the schools. I mean, the kids are out here suffering. I mean, I won't say physically suffering, but mentally suffering, because they need to be with their peers and being in the classroom and learning. And for the Board of Health to kind of ignore what the CDC is saying now, that even the CDC is admitting that hospitals have inflated the number of patients to, I guess, for monetary gain is what the CDC is saying now, that hospitals have been inflating the COVID rate because of monetary gain. Medicare will pay $13,000 to a patient that has to go on a ventilator, things like that. And even I think this even came from the CDC director, Robert Redfield. And again, you know, what's the end game here? We all know that Governor Cuomo in New York put patients with the COVID virus in the nursing homes. And for what reason? The U.S. Navy had a hospital ship right there in the harbor for COVID positive patients to go to, but he didn't. Governor Cuomo didn't even send them to the hospital ship. So it just seems to me like there's an agenda going on to promote fear in this nation, and especially here in Knox County, for no good reason. Last fall, we shut down the schools for a couple of weeks because of the flu virus going around. Nobody asked for masks then, so what's the difference? That's just things I've been thinking about, in the last couple of months, and I just believe that the question you should ask the Board of Health is, why aren't we following the model being used by Sweden, where there is no mandate or shutdown, and the death rate is a lot lower than they expected? I think we should take Sweden's example here in Knox County. Even here in America, I think we ought to follow it. But at the very least, open the schools back up. I appreciate your time and hope I've been some help to everybody. Thank you.
Thank you.
All right, next we have Marcy Yaden joining us on Zoom.
Can you hear me?
Yes, we can.
All right. I appreciate you all allowing me here. I want to talk about the integrity of this health board and your agenda, though. In October 31st, 2013, my raw milk dairy was raided with 7 cars and shut down for investigation. A week before this overpaid raid, I got a call from Martha Buchanan telling me that we had positive sampling. And when I asked for proof, it couldn't be provided because it wasn't true. We had bullying tactics used on us, and they investigated us for 2 weeks. And then on November 21st, if you look up the headlines, it was announced that we had a full-blown E. coli outbreak at our farm. We were then ran on national emergency broadcast system for 2 weeks straight, multiple times a day. A year later, when the numbers came out from the CDC, it showed that cases were actually down 50% that year. So I questioned it again. In return, I got a letter on 10/28 that says they have no idea why we were in the media and we were never confirmed the source of these outbreaks. I have that letter here currently also. And they don't know how we got in the media. So I want to know who alerts the emergency broadcast system, because I'm pretty sure it's not just a public person. So if the deal with my farm was to keep people safe, afterwards, there should have been something put in place, some new safety protocol, and that was never happened. It was just a smear campaign. So I bring this to your attention today, knowing that I was lied to further his agenda to ban raw milk. And I want to know why the current numbers are not being looked at against our population now. I understand in the beginning, we didn't know. Shut down, try to keep everyone safe. But now we have good numbers. And you've heard all the percentages over and over. They're super low. I know you all just want to keep us safe, but raw milk didn't kill me. We're still here, still drinking it. We're capable of keeping ourselves safe. So I also want to know some of these mandates, though, beyond the mask. How is not having a drink after 10 o'clock keeping me from catching COVID? How is putting restaurants at a half capacity, but then on the flip side, having everyone run through one side of the store so you can count them? It's counterproductive. The first one spreads people out. The second one packs people in. How does needing to know if I have an autoimmune system at the dentist? Right now, if I tell them I have an autoimmune system, they won't clean my teeth because I'm at a greater risk to catch COVID. What happened to informed consent, where I was told my risk and then I'm allowed to choose if I want to live with those risks? That's kind of what America was about, I thought, that we actually had a choice in how we run and how we operate. And if I think I'm at risk, I can stay home. I can put a mask on. I can do whatever you all think keeps me safe. But if I don't think I'm at risk, I shouldn't be required to do that. There's a whole list. If you look at your safety guidelines, that they counteract each other. And it's putting so many people out of business. It's unnecessarily scaring people. I've been talking to business owners everywhere. It's a bad atmosphere. They're being forced to put up signs, and they're being forced to enact policies that they don't believe in to stay in business. And it's wrong. We don't need to live in an atmosphere of divide and conquer and oppression and bullying. If this stopped, the people that were worried about it would wear their mask, and the restaurants that we're worried about will serve people with masks, and the ones that don't will not. I don't understand why everybody has to be all on one page when we see that the new numbers are not deadly.
Shaden, thank you.
Thank you.
All right, I think we're going to try again with Mark Whitmire. I believe we have him on Zoom and on the phone. So let's try that again.
Yes, can you hear me now?
Yes, we can. Thank you.
Perfect. Yeah, the phone wasn't quite working out. All righty. Well, I wanted to address you today about our county's handling of the coronavirus and the situation that the current edicts of the Board of Health have placed us in. I'm speaking to you as a former healthcare worker for a biomedical company which specialized in infection control and prevention. I'm speaking to you as a former student of the sciences in biochemistry and molecular biology. I'm speaking to you as a former member of the U.S. Army Medical Corps, and I'm speaking to you as a small business owner and as a son of two parents who sit right in the danger zone for the worst effects of this virus. So I thoroughly understand our circumstances. Most importantly, I'm speaking to you today as a concerned citizen who has seen the effects of the well-intentioned mandates go awry. Pardon the phrase, but the cure in this scenario has been worse than the illness itself. Since this period of the pandemic began in our region, more businesses have been shuttered than people have died. Out of 470,000 citizens in our county, we have regrettably and luckily only lost 59. While roughly 3/4 of the cases have been in people below the age of 50, only 5, a mere fraction of the 59 deaths, have been in people below the age of 44. This is according to the data on the Knox County Board of Health's website itself. This is also taking into account the fact that many people are already not following the mandates given. Mask wearing has devolved into being perceived as an identifier of political ideology. I have witnessed people berated for not wearing a mask, even though that person suffered from a disability that prevented them from wearing one. This has happened despite the Board of Health's specific exemption to mask wearing that was given for medical conditions. Shutdowns and fear of the virus have driven income shortfalls. More and more industries are being affected. Small businesses have suffered exponentially compared to the general population. I personally have seen my own business slow significantly in the past few months, and like a lot of other self-employed folks, I cannot draw an unemployment check. If I don't work, I don't eat. I understand that you're in a tough position, I do. But I also understand that sometimes, though we may not like it, life happens, and this virus is just part of life. Luckily, the coronavirus is not nearly as bad as we initially thought. The mandates may have been warranted at first, but now they are unnecessary and cumbersome. They have outlived their usefulness. I believe that the time has come to move from the realm of mandates to recommendations. Businesses should not be held accountable for the actions of their customers. Businesses should not be forced to close. We must let the people decide how to handle the virus in each of their own lives as individuals. We are a free people and we must continue to live as such. We must keep our economy going. We must allow for our citizens to make decisions for themselves. We must stop the needless division created by these regulations. So I implore you, end the fear, end the division, end the mandates, rescind regulations 2020-1 through 2020-5. Please use your position to help guide people, not order them. We will have far better results and a more peaceful society that way. I trust my neighbors to make the right choices. I hope that you will as well. Thank you very much for your time.
Thank you.
So that, Dr. Butcher, that ends our public forum, the folks who signed up. So you may proceed with the agenda.
Thanks to everyone who participated in that. We appreciate your input. And so with the completion of the public forum, the next item on our agenda is approval of the minutes from the August 26, 2020 meeting. Those should have been distributed electronically to everyone. And so at the outset, I want to see if there are any additions, corrections, deletions that need to be made on those minutes. And if not, I'll entertain a motion to accept the minutes as distributed with a second.
I make a motion we accept the minutes from the last meeting.
Second.
So we have a motion and a second for acceptance, and let's have a roll call vote. And Dr. Buchanan, if you'll lead our roll call, please.
Sure. Dr. Drake,
Yes.
Dr. Gocher,
Approve.
Dr. Hurt,
Yes.
Mayor Jacobs,
Yes.
Dr. O'Brien, who joined us,
Yes.
Dr. Shamia,
Yes.
Dr. Souza,
Yes.
Ms. Wagner.
Yes.
Okay. Minutes passed unanimously.
Minutes have been approved. Thank you. The next item on the agenda is to set the agenda. And you have the agenda again before you. It was sent electronically. Are there any items that need to be changed, added, deleted from our proposed agenda for this evening?
This is Maria. I'm not sure this is something that needs to be added to the agenda or if it just comes under other business. But I would like for us as a group to follow up on, because I don't think we came to an actual decision about adopting or adapting Knox County Commission's rules as ours, since we don't, we haven't had any. And they've been our de facto rules. So I don't know if that needs to be added to the agenda or if that's something we can discuss in other business, but I still lack clarity on what the game plan is in terms of, and I apologize if this has already been discussed with you, Mr. Sanders, and somehow I missed out on that conversation, but I just like some clarity, adapting, adopting, amending, tweaking, where we are in that process. I guess that's what I'd like to discuss.
Dr. Hurt, I talked to Mr. Sanders about this particular item, and we felt that probably under other business as a matter of initial general discussion, so that we can sort of distill our thoughts on it before we come up with some final recommendations, probably to be looked at the next meeting, if that's okay. If that's kind of the will of everybody, we can keep that in other business unless somebody specifically wants to pull that up, but it's probably preliminary to come up with a concrete recommendation because we really haven't discussed it as a body to speak of.
Okay.
Okay. So again, back to the setting of the agenda. Did we get a motion and a second for that? I don't think we did. So I guess, did we? Can we get a motion and a second for that?
We did not.
Okay, let's entertain a motion and a second to approve the agenda as written.
Motion to approve the agenda as written.
And a second. Any further discussion on the agenda? Motion to approve? If not, Dr. Buchanan, if you'll go through that roll call once more for us, please.
Dr. B, you're muted.
Thank you, Mayor. Dr. Shamia, you made the motion. Who seconded it? I'm sorry. I did not. Is that you, Dr. Drake?
I did.
Okay, thank you. Sorry. We'll begin the roll call. Dr. Drake?
Yes.
Dr. Gocher?
Yes.
Dr. Hurt?
Yes.
Mayor Jacobs?
Yes.
Dr. O'Brien?
Yes.
And Dr. Shamia?
Yes.
Dr. Souza?
Yes.
And Ms. Wagner?
Yes.
Okay, so the agenda is set.
Agenda is set. Thanks, everyone. Next item on the agenda is number 7, which is the Knox County Health Department benchmark presentation by Dr. Buchanan. So Dr. Buchanan, if you will give us that information, please.
One moment, please. I'm just looking for my notes that I had with me when I came in the room, and now I can't find them. So I'll play for you. Bear with me. Okay. I think I can. get through most of it. You got it? Thanks, Judy.
Sorry.
I apologize. Okay, so first, as usual, I'll kind of update you on the local situation. We have 104 new confirmed cases today, giving us 6,746 confirmed cases of COVID since March. Additionally, we have 241 probable cases. 4,611 of our cases have recovered, giving us 2,317 active cases. 269 individuals have been hospitalized at some point in their illness. Currently, 48 Knox County residents are hospitalized. And unfortunately, we did have another death to report, bringing our total to 59. I do want to point out that, as you can see, the 11 to 20 year-olds make up about 17 of the total cases since March. However, when we compare this week to last, they actually make up 36% of our new cases, which is a 158% increase just in that age group since last week. So that's very notable. We did anticipate this as schools and universities were reopening, but it's important that we and the board continue to encourage families, students, and everyone to follow the 5 core actions whenever they are wherever they are, not just in the classroom. So we'll move on to the benchmarks. First benchmark, sustained reduction or stability in new cases for 14 days. We've seen both red and yellow flags in the last 14 days, but they were not on 3 consecutive days per the benchmark definition. Because of this, we are representing this benchmark as green. However, we call this a cautious green because of the number of flags. While not consecutive, we believe they are an indication of a beginning trend upward for Knox County. Second benchmark, community-wide sustained and increased diagnostic testing with consistent or decreased test result reporting turnaround time. Over the 14-day period, we saw some red flags for the number of tests conducted, but they were not on 3 consecutive days. Lab turnaround time continues to decrease to less than a 2-day average. This benchmark is represented as green, but just like the first benchmark, I would call this cautious green due to the testing flags. Our third benchmark, sustained or increased public health capability. For this benchmark, we aim to initiate investigations for new cases within 24 hours and close contacts within 48 hours. We continue to be able to initiate investigations in this time frame. Because of this, our benchmark continues to be represented as green. With our existing EPI support team in place, we're able to handle our current caseload. We will, of course, continue to evaluate this and make any appropriate changes as the situation evolves. We've actually decreased our staffing based on last week's numbers, but we certainly can increase that if we need to. Our fourth benchmark, healthcare system capabilities remain within current and forecasted surge capacity. We saw no flags regarding ventilators, ICU beds, or hospitalizations. That said, hospitalizations are slowly trending up. After speaking with our hospital partners, they stated this benchmark should be represented as yellow. So that it is represented as yellow. Our fifth benchmark, sustained or decreased COVID-related death rate for identified positive or probable cases. Over the past 2 weeks, we have seen 4 deaths, which is down from the 6 we reported during our last update. We are pleased to say this benchmark is represented as green. While we are pleased with how the data is looking this week, we expect the first 2 benchmarks may change next week. We will continue to closely monitor the data as always. And I'm going to give Catherine a little time to pull something else up. We're going to look at some trends related to our past over the summer season. So we're looking at this as local data from a few of our recent holidays, which we believe is timely ahead of the Labor Day weekend. So this is Memorial Day. And you'll see that 2-week incubation period, we saw increases in cases. And what you need to make note of is the new cases per day. The range for the new cases per day on this one is up just to 25. So if you remember back in May, our cases were pretty low and we were kind of just creeping up, but this is where we kind of started to see the increases. Next is following Father's Day. And you'll notice again, the range has increased quite a bit, up to 100. And you'll see that after that 14-day incubation period, our cases certainly went up after Father's Day. And then if looking at the 4th of July, and again, you'll see that the range has changed up to 160 cases per day. And again, we saw a little bit of a spike after 4th of July. And I just think that's a reminder for all of us that with the Labor Day holiday coming up, we all need to be very diligent about practicing the 5 core actions, and especially in those arenas where we feel really comfortable, like with our families and friends. We need to remember to continue to practice those. So any questions about the data or the benchmarks?
Dr. Buchanan, you had mentioned that you expected to see some of those benchmarks possibly change within the next week or two, and specifically number 2 on testing. Is it that we will have less testing, longer turnaround times? What is your prediction on benchmark 2?
So on benchmark 2, I think we've seen a decrease in testing over the recent past. But I expect, like in the past, as our cases have gone up, testing has gone up. So I expect demand for testing to continue to go up. And then that will potentially increase the need for testing. But sorry, let me flip that backwards. With testing, it's actually, we're worried about testing rates going down and not finding cases. So we've seen that trending down a little bit over the last few weeks, and we're concerned it will continue to trend down. And then we'll have people who have COVID, who don't know they have COVID, and putting others at risk. So sorry, I had to think about that a moment.
How about our turnaround time on testing in the county? Is it
Turnaround time is great right now. With testing volume going down, turnaround time is improved. If testing volume goes up, turnaround time does tend to go down or up also, because it takes longer to get the test back. But those are just some concerns we have. Anecdotally, we're hearing that people are not getting tested because they don't want to be put in quarantine. They don't want or being put in isolation. They don't want their family to be put in quarantine. So that's certainly a concern we have, to have people unknowingly putting others at risk because they don't know they have COVID.
Thank you for your report. Any other questions from the board on Dr. Buchanan's report or comments? If not, we can go to the next item in the agenda, which is the University of Tennessee Medical Center's Knoxville data by Dr. Shemaya. So James, if you will give us your report, please.
Thank you. So as tends to be the case, I think this will tell a consistent story. I do have a few specific things I want to point out. So next slide, please. So this is kind of old news at this point, but both in the county and the Knoxville district, we continue to have a strong correlation between hospitalizations and new cases diagnosed. And so nothing specific to point out there. Next slide, please. So the new cases diagnosed, and again, as always, this just moves toward the hospitalization piece. Here you see that in Knox County, we did cross that 6,000 point. This time it took us 13 days to get from 5 to 6,000 cases, which was longer than the 11 before. Across the district, it is more level in that kind of 5-day range to get to that next 1,000 cases. Next slide, please. I think this is more notable, though. I want to stop here for just a moment. And so there you see in Knox County, where we had that peak week of 889, and then the fairly abrupt drop to 665. And the decline had slowed, and now we've started to go back up. Now, I suppose this is potentially newsworthy, but it's not that we've dramatically gone back up, but I think it's very safe to say that the decline appears to have stopped. The other thing I'd point out on the right is you see that in August, even with that decline, we had almost an identical number of total cases as we did in July. The district shows similar data. It's also seemingly leveling off. Next slide, please. So this is our doubling day growth rate, and we have shown this before. Some of the nuances of this is that we have to really be careful about watching when the yellow line and the blue line start to cross again, because that would be an indication that the doubling day rate is going back up. I think this is something that we're going to be needing to watch closely in the coming weeks, and this can be one of our leading indicators of what's going on. Next slide, please. So I've shown this before, and this just compares the trends. Shelby County has been somewhat erratic. Davidson County has had a very smooth decline. I mentioned that Hamilton County was ahead of us on a few things, and they were increasing, but I think it's safe to say that they're unstable. And then, of course, what I've already shown you about Knox County. Next slide. So then all that builds up to hospitalizations. And similarly in Knox County, there was that very abrupt decline and then a more steady leveling off. And based on what we're sensing, and we're still having that community-wide capacity call among all the systems, we're doing that 3 times a week just to check on each other. And our sense is that that's potentially increasing with the district, again, kind of lagging behind on that. And so those are new hospitalizations. Next slide, please. So this is, I want to spend just a moment here. So the census is the number of patients hospitalized on a given day across those counties. And what you see there at the end, I've mentioned just about at every meeting that some of the jagged nature of this can be related to when not all the data is reported on a given day. So this is really valuable for trending over a period of days and not any one given day. But that 125, I believe, represents 4 steady days of increase in hospital census across the district. So certainly not back up to that 185, but a lot of this is about anticipating trends as we think about decisions. And as I've said, every time wanting to set the stage to make data-driven decisions. And so with that, next slide, please. So this is our projection based on, and you see that, I always make the caveat that this projection is not intended to be overly scientific. It just kind of takes the trend that we're on and projects it out. But if the steepness of where we were headed in the last 4 days were continue, we would certainly be higher than that. But this is the mathematical piece. And next slide, please. And you see that the blue line is what I showed you last week. And then the yellow line is what I've just shown you. And if you recall, when we were on the way up, I was showing numbers that were closer to 400 out at around at the middle of September. Next slide, please. So I don't show this every month, and I have to clarify, this is at UT Medical Center. So this is not Knox County specifically. These are patients that, for the counties that we serve, but the patients that we see or that we have seen compatible with all the data that Dr. Buchanan mentioned. We certainly have seen a slowing down of mortalities in August compared to July. I do want to make a specific point as this comes up, I think has come up several times, is there is no comparable flu slide that I could show you. This is nothing, the volume of these mortalities is very distinctive related to this. And the one way as a pulmonologist and intensive care doctor that I could contrast this to the flu is that influenza deaths that we see are nothing comparable to this. Next slide, please. And then this, I also want to spend a moment on. I feel like part of our responsibility here is to educate. And I feel like that this is one where I want to spend just a moment and clarify what comorbidities, what they mean, and what they mean in patients who become more severely ill. So comorbidity is when someone has more than one medical condition. And the way we describe this and the way we use this word is generally we're referring to long-term or chronic conditions, more than one in the same person at the same time. And on that slide that I showed you before, in our experience, the way that COVID-19 typically leads to a death is through respiratory infection and inflammation. And people with comorbidities are less likely to be able to fight the virus long enough or with enough vigor to survive the illness. Now, COVID-19 can also lead to mortality by essentially starving the body of oxygen and causing the other organ systems like the heart to fail. Patients with comorbidities are less likely to tolerate this. If you could go to the last slide, please. Go backwards one slide. I'm sorry, could you go backward 2 slides? So when I show this, these people, of the people here who had comorbidities, the comorbidities made it more likely that they were going to succumb to COVID-19. But we feel, with very rare exception, these people were sick and were in the situation they were in because of COVID-19. And it was those other conditions that made it more likely that they were going to succumb to COVID-19. And I'd be happy to answer any questions about that, but I want to make that point clear, is that in virtually all of these situations, not every single one, but virtually all, our sense was these people would not have been in the hospital at the time that they were if they had not had COVID-19. If you could forward 2 slides, please. And then Dr. Buchanan, I wanted to also really ask about this, because I think there's also some ongoing confusion about this issue in terms of your recommendation about, I mean, this is Dr. Shamia's sense, based on dealing with this for all of this time, is that we want people, if they're having symptoms, to be tested. I still sense that to maintain contact investigation and to control a pandemic, we want those with close contact of an active confirmed case to be tested. I think the challenge there has been people get this sense that if they get a test, then they don't have to be quarantined, which has led to some confusion, but it doesn't mean that the test is not important, or if you're advised by a healthcare professional to get a test. And so I specifically bring that up because I wanted to get your sense of again, from an education perspective, where we are on this issue. And I believe, could you hit next slide, please? I believe you can go back one. I believe that is my, yeah. So, but that actually move one forward to the testing guidance. So Dr. Buchanan.
Sure, thanks, Dr. Shamia. Yes, these are the primary folks that we would recommend get testing. I say that, but then also say that we, the Knox County Health Department, are not turning anyone away who presents for testing. And we continue to have messages from the state leadership about everybody getting tested. So that sometimes can be confusing for people. But the people who really need and that we would recommend testing are the ones you've listed here. There does continue to be confusion about getting a test and being able to get out of quarantine. You can't test out of quarantine. Also the timing, if you're a close contact of an active confirmed case, getting tested right away doesn't really inform you. You need to wait a few days after that contact, 5 to 7, where you're more likely, if you're going to be positive, to have a positive test. You still have to stay in quarantine. And one of the other challenges has been honestly educating healthcare providers about the utility of the tests and how to advise patients. So that's something we've been working diligently on here at the health department, so that all of our healthcare providers are giving people that they test for COVID the same message, that you need to quarantine until your results come back. Certainly, if you're ill, you need to isolate, but it's not been consistent across our community.
Thank you very much for that. So I'll be happy to take any questions.
Any questions or comment from the board on Dr. Shamia's report?
I want to thank you, Dr. Shamia, for helping clarify what comorbidities are. There seems to be some confusion in the public about, how deadly COVID really is in and of itself, and about the numbers in terms of, cause of death purely and only to COVID versus other comorbidities that have, of course, exacerbated, made it much less likely that someone who's acquired the virus to survive it. I'm wondering if you can, or perhaps Dr. Buchanan can just address some of the confusion people have that COVID is less deadly than the flu. And of course, we know the flu comes around every year. There's short-term immunity. That's why, we have vaccines every year. And people do die from the flu. That is true. I wonder if you can just address that, because you touched on it in one of your slides about there's basically no comparison in your experience as a pulmonologist, and you see the sickest of the sick people. So if you could address that or shed some light on the difference between the two and how deadly one is versus the other.
So I can start on that, and then Dr. Buchanan absolutely can hand off to you. So I have our data, our hospital's data, as far as flu deaths, and these are confirmed flu cases. And in a not bad flu season, we may have single-digit actual deaths from influenza. And in 2018, for example, where it was a worse flu season in general, and the things that affect flu season is how effective the vaccine is, and then sometimes some years flu bug is just nastier than other years flu bug. And I believe in that year we had 16 deaths of confirmed flu. Now, sometimes there are presumptive flu cases. It's harder to track those, but still, those numbers are substantially lower than what I just showed. The experience that the physicians have in taking care of those patients in a bad flu season versus what we encountered in July, in late June and early July. I mentioned that we had a single Saturday with 4 COVID-19 deaths, which is not something that in my career I can say I've seen in a day with the flu. One other thing I want to make, one other point I'd like to make about just comorbidities is that, guys, this is true across the board. The more chronic medical conditions you have, the more likely anything is going to create a significant issue for you. That could be a heart attack, that could be a car accident. So that's not unique, but still there's that inciting issue that leads to people being sick. And so what seems to be the case with COVID-19, though, is it's just very significantly, it tends to have a predilection to be more severe in those people, both based on age and based on number of comorbidities. So Dr. Buchanan, I don't know if you have anything to add to that from what I'd said.
I really don't. I think that's a really great summary from somebody who's in the hospital caring for these patients. We certainly can find the data on the rates of death from COVID versus flu, but you have Dr. Shamia here who's been practicing for years and can speak to that experience and what they're seeing. And what he's seeing at UT is not unique to UT. They're seeing it across the community in COVID patients. And I'm hearing similar things from his colleagues about how it's really challenging to care for these people, these folks, and that they really can get sick rather quickly. So it is a rather lethal virus that can cause some significant respiratory distress and illness.
And just one more point I'd like to make is, unlike what I've generally seen in the flu, and I don't have the statistics behind this, but we have to remember that COVID-19 still in what our perception is in the care side, a very random way can cause quite severe disease, even death in a perfectly healthy individual. And while the flu can do that, I'm not saying it's impossible, that's just not something that we may go, a period of years between when we can see that. I'm talking about my own clinical experience and hospital experience between when we see that related to flu. And so, I mean, that's something that has left an impact on us, is to some extent the randomness of where, those people who don't have all those comorbidities, who didn't fit that classic picture. It doesn't seem like there's a rhyme or reason to why necessarily those particular people became so sick.
Thank you.
Thanks for those comments. Any other comments or questions from board members?
I just have a quick comment. I'd like to thank Dr. Shamiya, people at UT Medical Center, and all of our hospitals who have worked so well together. And just thank you guys for doing that. I don't think that's true across the country of the hospitals coming together and working like they have here. So you guys have done a wonderful job. Thank you.
Well, thank you for saying that. And I'd just like to thank all of our hospital partners, because it's truly been, just the level of collaboration, even just getting on these calls several times a week, just to check on remdesivir status for the antiviral medication, bed status, things like that, that's not happening in every community, I guarantee it. Thank you.
Thanks to everyone. If there are no further questions or comments, we will go to the educational institution presentation. And let's start out with Dr. Gregg from the University of Tennessee. If you are ready, Dr. Gregg, for a short presentation.
I think I need to.
Dr. Gregg, I'm here also.
Okay. I think Dr. Plowman was going to start, if it's okay.
Sure, that'll be fine. Thank you for your attendance, Dr. Plowman, and go ahead, you have the floor.
Absolutely, thank you. Good evening, and thanks for having me and Dr. Gregg, who has been just so invaluable to us in this process. The University of Tennessee takes really seriously the fact that we're part of this community, and the community is part of UT. So our relationship with you all is incredibly important, and it's been an amazing partnership up to this point as we struggle with this challenge, this opportunity that's ahead of us. Dr. Gregg, as you know, is director of our Student Health Center. He's also the incident commander of our Emergency Operations Center. And that has been active since March, up and running every day. It was never designed for an emergency that lasts forever. We're still into it. So we keep talking about that every day. But he's in regular contact with Dr. Buchanan, and we feel that partnership has helped us so much. Every decision we make is guided by the advice we get from Dr. Buchanan, her colleagues, and other public health care experts. So I want to share with you the latest data as of today, and then I want to talk through how we see that. And I'll ask Dr. Gregg to jump in here too with any comments. So as of today, we currently have 243 active positive COVID-19 cases. So what you see here on this chart is two things that are important to me that I'm watching every day is what's happening to faculty and staff. They're in that blue line at the bottom called employees. The green line is students, and then the total. So you see that classes started on the 19th. Students began moving in the dorms on August 9th, and you see what we expected to have happen actually. Currently, our Student Health Center under Dr. Gregg's leadership tests students who are exhibiting symptoms of COVID-19. We made the decision not to try to test every single student as they came back, We encourage students to get tests before they came back and not return, of course, if they had a positive case. But we test students who are exhibiting symptoms of COVID-19 or who have been identified as a close contact with someone who's tested. So our health center is managing that. We also receive the positive test results of students who were tested elsewhere from the county health department. So all those are in this number that you see. Members of our campus community who test positive for the virus are required to self-isolate. Residential students self-isolate in space that we have designated or at home if they live within, a close radius. Most of our students isolate away from campus, and that is because most of our students live off campus. Out of the 30,000 plus students we have enrolled, only something like 6,800 live on campus. Now, we also manage quarantine space for residential students who've been identified as close contacts or who are waiting test results. Now, I want to show you on this bar chart what you see here. Let's look at the one for September 1st. That chart shows you the number of people who have filled out a self-isolation form and have told us they are self-isolating. The green part of that bar shows our residential students, and the blue shows those non-residential students. We continue to adapt our procedures and processes about how we quarantine students, and I'm just going to say that up front. We will continue to adjust that based on quarantine spaces and other matters that affect our decisions. So right now what you see is we have 1,253 people in quarantine or self-isolation. I'm lumping those together right now. Isolation being for those who tested positive, and quarantine for those who are awaiting test results or close contact. Of those, 1,189 are students. So that is something clearly we're watching. Now, I would say the good news about the higher numbers means the students are doing what we've asked them to do, which is to report with the self-isolation for it. Students and employees who are in quarantine or self-isolation, as I said, are asked to fill out a form letting us know. From there, our contact tracers, who are an extension of the county's contact tracing team, begin their work. We post daily updates on the reasons people are self-isolating and quarantining. So you can see in this chart, and all of this is on our website, but right now, 15% of those who are self-isolating have had a positive COVID test. Almost 50% are because they've been identified as a close contact. 23% have developed symptoms, and 11% are for other reasons. Maybe that's something like they traveled or something like that. So what you can see is the close contact quarantining group has grown. And that is the number we're watching, and how we manage quarantine spaces will continue to adapt as we go. One other measure that I want you to see here and that we post is the clusters. We have identified in the last 14 days these 5 clusters. Now, we define a cluster as at least 5 positive cases that are linked together around an event, or at least 20 close contacts as a result of one event in one concentrated location. So you can see there's a common thread there. That shows you 5 sorority houses. So we've identified 6 clusters since early August, 1 related to an off-campus party, and 5 directly tied to sorority and fraternity houses. That's an area we're having to work on. Let's talk for a minute about the rise in our case counts, because you saw that sharp, steep curve. If you've been following our data, or tune in, and I invite you to do that, we have live updates Tuesday and Friday at 11:30 for 30 minutes. If you've been tuning in, you know that our COVID cases have been rising, as have been the number of people in self-quarantine and self-isolation. And again, I say this is not really unexpected. You bring all these people back together, 30,000 students, and we knew some of this was going to happen. Now, as you know, it typically takes a couple of weeks for exposure to the virus to show up as a positive case. So even today, we're still seeing increases that were driven just by the start of the semester. We continue to monitor our campus data along with the key metrics reported by the county and the state health departments. I remain confident in the processes and the infrastructure we have in place to manage this. But I want to be clear that we will continue to adjust the processes, the procedures for how we handle quarantining, what the spaces are, and how we handle it based on our volume and our capacity. Now, one other thing I want to share with you is that we're going to soon begin surveillance testing on the campus. We have converted existing labs of some of our faculty members who are going to be doing different types of surveillance testing, and Dr. Gregg can talk more about that. That will lead to additional testing, and we will identify individual cases. But the hope is it will help us prevent further spread of the virus and to help contain it. But again, remember, it's also going to lead to the identifying of more cases because we're going to be testing more. Let's talk just for a minute about those clusters. They're in our sororities, and right there what you saw was in the sororities. Over the summer, each fraternity and sorority house, which are operated under the auspices of their national chapters, submitted operational plans to the university. And as we've begun to implement those plans, now that we've had a few positive cases, we've had some bumps on the way, and it's represented in those clusters. We're continuing to work with the chapters to perfect, to improve how we handle quarantining. And once we get a positive test, the positive test moves out of the house. Now that we're into the semester, we do see some opportunities to improve how we're handling that. We've begun a full review and reassessment of the operational plans for each sorority and fraternity, and we're going to work with them in the coming days to make sure there are plans in place that address the right standards so that members can quarantine in the house if they choose to do that. So I'm going to stop right there and say I really appreciate you having me and Dr. Gregg. I would ask Dr. Gregg if there's anything you wanted to add to what I just said there to further clarify anything.
Thank you, Dr. Plowman. I think that you've laid out here what we've been seeing since the start of classes, and like you've said, it wasn't that these increases were not what was expected. We certainly attempted to plan ahead as best that we could, but we are seeing that there's some areas that we can go back and tweak to improve further, and we'll continue to do that. And I'm sure as things go along, we'll probably find other areas that we can improve on as well.
So we're happy to take any questions if anyone might have them.
Any board members with any questions or comments for either Dr. Plowman or Dr. Gregg?
So, Dr. Gocher, I have a couple. First of all, Dr. Plowman, thank you very much for that very informative presentation. And one of the things that I had mentioned in our last meeting, and this question is really directed to both of you, was just that the types of regulations or limitations, if you will, that might be helpful to either a campus or the area around a campus may not be the same types of things as for the county at large, just because of inherently life is different and the amount that people are together is different. And so we discussed some of those, that's kind of inherently challenging for us because the success of the university is so important to the county, but it's one piece of the county. And so I guess my question to both of you, is there anything in particular that this board could do within the confines of what it's able to do that would help you? One example is, a gathering size number, if you will, what your right number is and what our number might be, consistent with the Tennessee Pledge or anything else may be different. And for me, it all goes back to the 5 core actions, is that if there's a situation that inherently makes it less likely that the 5 core actions are going to be followed, that's where all these other things become more important. And so is there anything we can do to help you?
Oh, well, what I would say is, and I'll let Dr. Gregg take a cut at that too, is that students want to be together and we want them to be together, but we want them to be together in a way that's safe. And the biggest thing is if you gather with, and they know the number is 50 on a weekend, that it's just hard to wear your mask and get together with your friends. So I think that we're working really hard with them on wear the mask on campus. They're doing it. They're in the classrooms across the campus. If you drive through, you see it. We know that's not happening when they gather at the bars or when they gather with their parties. And what I've said to the students is we want you to be together. You just need to be with your mask, especially if you can't be 6 feet apart. And so I think that anything that we can do to help encourage them to, the mask mandate helps, but the size of the group gatherings, I mean, they're kind of honed in on, if we have 50 of us and we've got our masks and we don't, I mean, none of it, it's just hard to socialize wearing masks. So I don't know exactly how to guide the board. I mean, if it would help all of us if we were, our problems occur off campus, not on campus. On campus, we got pretty good control of that, and students have the masks on. So if people aren't going to wear the mask, then it seems like the staying 6 feet away from each other in larger groups would help. Dr. Gregg, I don't know if you want to add anything to that.
Yes, what we're finding is that students that by and large, when they're getting in these groups, they're kind of focusing more on the number. And so their take is, well, we've got less than 50 people here, and so we should be okay. I think there's a disconnect between the size of the group and still the need to maintain that 6 feet of physical distance for less than 10 minutes, not to be within 6 feet for more than 10 minutes, and then to keep that mask in place any time that you're at risk to breach that physical distance. And obviously, the larger that group is, the more likely they are going to be coming in contact with a greater number of people. And they do tend to focus on the number. So I don't know that for our campus that 50 limit is necessarily the right number, but I don't know that we can say specifically what that right number would be. Certainly not more than 50, but I don't know that we have the expertise to know what that number should be or where that cutoff should be.
Dr. Gregg, we discussed, I think maybe at our last meeting or meeting before, just briefly, that the CDC recommendations specifically don't have numbers in them because it's multifactorial, and it really gets back to the 5 core actions in terms of those factors. And an example we gave is if some large group were outdoors and they were socially distanced and wore masks, it's a completely different situation than that same number of people in a tight indoor space with no masks.
Yeah.
So it's multifactorial.
Yes, without a doubt. And the issue is that when students do gather, unfortunately, it doesn't tend to be in large open outdoor spaces, but it tends to be in group settings within an enclosed space most of the time. And I think that's certainly a contributing factor to what we've been seeing here on campus.
I guess my sense on this is that, I mean, we have to be just as practical as we can be. Yeah. And essentially, so the classroom, for example, I mean, that's an environment highly likely for the 5 core actions to be followed.
Yeah.
And based on the nature of COVID-19, outdoor spaces do not concern me as much.
Yeah.
But, indoor spaces and just using common sense, the more people you have, the less likely distancing and mask wearing are going to be effective. So I guess my question would be is, I mean, you clearly seem to be addressing things through the code of conduct, and you are able for the camp. I mean, you should be governing your campus and not that. But at the same time, if there's any if it would help you that we debated what would be a more appropriate gathering size for a group that is more communally living like that, we could do that. or if you have the ability just to, if you ever chose to do that yourself, then we don't need to do that. I just want to, if there's something you need from us either today or going forward, I just want that to be very open and clear. That was part of my intent.
Well, you know, one of the things we did with, we are using the student code of conduct. We have not addressed a number in it. Our student code of conduct says you can't jeopardize the health of someone else. So what we've said is if you have a party, if you host a party where there is, and we didn't even say anything about the size. If you host a party of 25 and they're crammed into one room and no one has on a mask, you have endangered the health of other people. And so that's the only way we've figured out on campus that we can kind of come down on it, and is really focusing on the host rather than the attendee. Other schools have looked at the attendee. I don't think it's worked out that well. And so we're just really trying, but I think if you give people a number, they're going to say, if the number is 50, they're going to have 50. If the number is 25, they're going to have 25. So I think we've got to just help people try to think about the larger picture, but it's a struggle. And, you know, if you close a bar at 10:30, but you leave open a restaurant that has alcoholic beverages, they're going to go over there. So it just kind of, we just got to all work together. So our goal at the university is to try to help students realize, and most of our students are doing a great job, I just want to say. And we don't want them to not be social animals. We don't want that. We just want them to do it in a safe way.
Thank you.
Thank you all.
Any other comments from the board? If not, we really want to extend thanks to Dr. Plowman and Dr. Gregg, and hopefully we can count on you for future reports as well.
Sure.
Thank you so much for your help, and thanks for your actions that you've taken to this date to try to help us out with those crowd sizes and that student code of conduct. It's been useful beyond our imagination. Excellent.
Okay. Thank you.
Can I ask a quick question, please, Dr. Goetzer? It's actually for Dr. Buchanan.
Yes.
And Dr. B, you've already answered this last week, but pertaining to the numbers at UT or any other schools, where do those go? Like into our count, into the home county of the student? And I said that, I know we went over that a little bit, but could you refresh our memory on that, please?
Sure. So students that are attending UT and living in Knoxville or Knox County while attending UT go into our counts. If they go home because they get sick, they will be transferred to that jurisdiction, or a staff member would do the same. So it's the jurisdiction where they're living, that's where their case counts.
Any other questions or comments? If not, I would like to turn our discussion over to Ms. Wagner. If you have a report from the Knox County Public School System, would appreciate that input. Thank you.
Okay. I see the PowerPoint.
Give me just a minute to screen share. Yeah.
Okay. Can somebody go to page 2? Okay, this is the Knox County Schools COVID dashboard. And this data is from yesterday. So the number of active cases for students is 23, staff 24, which gives us a total of 47 new cases. And so if you look from August to September 1st, the dark blue is staff and the light blue is active students. So today's count we have 29 students, 19 staff, which makes a total of 48 active cases. Next slide, please. So this just gives you like a bar graph from August 24th until September 1st, how many cases we have. Like if you look at August 30th, we had 14 active staff and 13 students, active students. And yesterday we had 24 and 23. Next slide, please. So this is the number of recovered students, and it's we have 28 recovered students and 52 recovered staff, which makes a total of 80. So next slide. So before we developed a new system where our research department did. And so we used to put the numbers in manually, but now we have a new way of tracking that gives the automatically gives the output of numbers. So the number of recovered cases are from June 8 to September 1st. So 27 and 50, August 31st, and 28 and 52. Next slide, please. So we have 412 students in isolation or quarantine. We just combine those. You know, isolation is for those with active cases, and quarantine or for contacts. And the same for staff, 85 in isolation or quarantine, which gives us a total of 497 of students and staff combined. Next slide. This is the same thing, it's just isolation and quarantine. So from August the 24th, we had like 25 teachers in isolation or quarantine and 255 students in isolation or quarantine. And as you can see, it's gone up from August the 24th to September the 1st. 85 staff in isolation or quarantine, or 412 students in isolation and quarantine. Next slide. We've been getting a lot of questions about what these different bars mean. And so the green bar is student attendance, and then the next bar is teacher and staff attendance, bus service interruption, and cafeteria. So it's based on a model pretty much like the health department. And so, you know, you have the green, which is go, which is good. So we have good staff attendance and so on. And then the yellow, custodial support, staff in attendance. That means, you know, it's a yellow light. And then the red is substitute availability, which is in red. Currently, we don't have enough. We have substitutes, but we could use a lot more substitutes. Next slide. And this just gives a meaning of what the green, yellow, and red means. So just say, for instance, in the yellow, teacher and school-based staff attendance rate between 90 and less than 93%. So that just gives a definition to the different bars, green, yellow, and red. Next slide, please. I just want to remind everybody that we have in our department, the Knox County Schools Health Services Department, including 83 school nurses, have been trained and authorized by the Knox County Health Department to conduct contact tracing. And this process begins as soon as a positive case is confirmed. And if we have a positive case and it is confirmed at the school, a notification is sent out to families and staff at school. Next slide. Next slide, please.
That's the end of your slide deck?
Oh, it is?
Yeah.
Okay. So, like I said, the numbers are updated after 4 every day, probably at 4. And so you can go to knoxschools.org/COVID to see that. So if you look at our cases, we do have some cases, but in relation to our student population, which is about 42,000 and over 8,000 employees, it's kind of low. I mean, one case is too much, but I'm saying the numbers are pretty good right now. Not saying that it won't go up later after Labor Day and, you know, as we get settled back in school. This is just the second week of school, but they're pretty good right now. Any questions? I know that was pretty quick.
Very well done. We appreciate that. Do you have any information on any hospitalizations arising from COVID positive students or staff?
We only had one staff that was hospitalized, and that was way back in June. But since school opened, we haven't had any that I'm aware of. Yeah.
Thank you.
Lisa, I have a question.
Yes.
Does every school have a nurse?
Every school has a nurse, but not every school has a full-time nurse. Now we have expanded that where more schools have full-time nurses, site-based nurses. But every school has a nurse, but just not every school has a full-time nurse. They're every day, all day. Yeah.
I'd like to follow up on that. First of all, thank you for the presentation, Ms. Wagner. And I apologize, because my sister teaches in a school system in a county adjacent to this one, I get my facts a little mixed up. So for my understanding and for everyone's clarification, can you walk us through the process, for example? So children show up to school in the morning, and then just if you walk us through the process, are they all screened, or do you does the nurse wait until the student says, I don't feel so good, or I guess the teacher would? If you could just walk us through kind of a typical scenario of how these children are identified.
Yes. So when they come in the morning, every student's temperature is taken, every student. And so those that have an elevated temperature or complain of symptoms are sent to the nurse, and somebody evaluates them further, you know, asking the questions that we ask everybody. And sometimes children don't present with, you know, just a fever. Usually they don't have a fever. They have other symptoms like a stomach ache or something like that. And then we communicate with the parents and talk to the parents, and then they're sent home if needed, things like that.
And so who's doing the testing? Just so I can get clear. So the child presents and they have some symptoms, and then the school nurse makes the contact with the child's family.
Yes.
Then is it just suggested, like we think perhaps this might be, or we definitely should take the child to be tested? I'm assuming that the school itself is not doing the testing. Is that right?
That's right. We're not doing any testing. We strongly, you know, we suggest, you know, we think your child should be tested, but it's really up to the parent. Mm-hmm. Now, if they have a fever or two or more symptoms or something like that, then they have to bring a note. They have to be fever-free for 72 hours, and then the doctor has to rule it out, and they have to bring a note to school for that.
Thank you.
Thank you, Ms. Wagner. Any other comments, questions for the educational institution presentation that we've had? Right.
Dr. Gosher, just a quick question, and also thank you for that presentation. So just on the custodial piece, I guess thinking from a public health perspective, I mean, that one seems to be, I know it's yellow right now. I mean, do you sense that's going to be okay? Because I could see how that would be even more important in this environment than perhaps it always is important, but even more so now.
Yes, I think it'll be fine. I mean, we do have custodial staff. It's just we're kind of low right now. And if we have a case, then we have what's called a dream team, and they go in and sanitize the place with this special mist or some kind of product that they have, and do that. So we do have enough custodians for the school. It's just that we don't have as many as we used to have. I guess I should put it that way.
Okay, thank you.
Mm-hmm. Thanks. Any other questions, comments on the educational institution presentations? If not, we can go to the next item on the agenda, which is the face covering regulation 2020-1 and a review and discussion of that regulation. Comments, questions, discussion?
So from the complaint side, that was on my notes, Charity. That you had. Hold up. Oh, the notes. Sorry. We did have complaints on my presentation that I seem to have lost in the process.
But I'm getting it back.
But Charity's pulling it back up. But I think complaints have kind of stabilized. I can't remember.
Sorry, that's very loud.
So for the week of August 24th through 30th, non-food businesses, we had 22 complaints. For food, we had 17. And I think the follow-up is similar to what it has been. A lot of times it's just clarification, helping people understand what they need to do. That's mostly what our staff are doing at this time, as far as the regulatory or the compliance side of the mask mandate. And then the other thing, we had said we would explore what kind of data we could use to make a decision about when to remove the mask mandate. My staff and I have looked, and as we've all said, as we all know, this is a really new situation. We've been asked the state, but don't really have any hard and fast data out there. One of our thoughts, as my team and I were brainstorming about what we could do, is we already have our established benchmarks to take those benchmarks and say that if we see decreasing case rates or case numbers over a 4-week period, and we also see a decrease in hospitalizations and a decrease in deaths over that 4-week period, that would be one way to use those benchmarks. An additional piece of data that I think we should probably, if we want to consider that, we throw in there would be a set number of cases per day. Because if we're getting 500 cases a day, if we're going down to 300 cases a day, that's not the time to lift a mask mandate. We haven't been there, but we could be there. And so, and that was also a suggestion from the state is, a number of cases per day. So in addition to cases going down, you have, 20 or fewer cases per day. And then, you could really feel comfortable that it might be appropriate and safe to lift a mask mandate. And that's just for thought. Obviously, y'all are hearing this for the first time, and I can certainly summarize that in writing and send it out to y'all for you to absorb and consider. And I don't know if anybody from the board did any research found anything out there that we just didn't find on what anybody's using to decide when to stop having a mask mandate. And it's certainly appropriate. You don't want to put something in place and not have a way to decide when to take it out. And we certainly don't intend for the mask mandate to be in place forever. And I think there's been some confusion about the mask mandate might have to be in place till we get a vaccine. We just don't know. We don't know what cases are going to do. And I also would say we have to have a caveat that if cases go back up, we might need to reinstate a mask mandate. If we were to drop it and cases went back up, I think it would be our duty to reinstate it. So those are just my thoughts.
And to say real quick, just that number that she just tossed out as an example was just an example. That wasn't a, just so everybody knows, that 20 or whatever, that would be up for discussion.
Dr. Buchanan, we know that Williamson County just lifted their mandate, I think, over the weekend. And I was wondering if you had any information on what their guidelines were, or what their metrics were to go ahead and lift that.
We can certainly ask. I don't know. We can reach out to them and ask. I know that the benchmarks or guidance they used to decide about schools was something they just kind of discussed and created. But we're happy to ask them. I don't have any information on that.
Thank you. Any other comments from board members?
It seems that we do need to look at this and try to come up with something so people have an understanding of, when we can lift this. But I just don't know that we're there today. I know we aren't there today. and then we're going to need to see some persistence of at least probably 28 days of something where we kept our numbers down and we do not have a rise in hospitalizations, active cases, et cetera. And it may be something that takes a little bit of time. We don't want that, but I don't think we're there to know that yet. We can't really predict today, and I don't think today is the day we would want to lift that, even though, I think Williamson County, that was done more politically. They don't have a board of health, and that was something they decided to do. But I think we are on the right track. We're seeing that masks have seemed to help quite a bit. I still see masks being used in the community, but I would like us to, just be cautious. I think the mask aspect of this is the least intrusive way of dealing with this, even though a lot of people feel that there are issues with that, being told to wear a mask, but it appears to be doing its job for us, and we want it to continue to do so. So I think we just need some persistence of good numbers, whatever they are, to make a decision.
I believe as a board, and Dr. Buchanan, correct me on this if I'm not right about it, but I think we are reviewing this on a weekly basis, are we not?
Yes, we are.
Good. So we'll keep looking at this information, and as soon as we have a sort of a solid system in place, we can look at some other places where the mask mandate has been lifted and look at their metrics. I know we've talked in the past a little bit about positivity falling below 5% as one metric, not the only one. But right now we are above that benchmark.
Right, and based on state data, Knox County is right around 9.6 positivity rate.
7 days.
Yeah, that's the average the past 7 days.
And we've talked about how positivity is a simple one to get a grasp on, but it's not a very precise instrument because you can't have a large outbreak in a small viral community. For example, a penal farm or prison.
And it's also not something we are able to track accurately on the local level.
And Dr. Gocher, I did want to ask Dr. Buchanan a question because, positivity rate comes up repeatedly. And I understand that we have some concerns about our our confidence in that number as it's tracked for reasons that you've described multiple times. But it's more just the understanding of what it means is what I have the question about. I mean, I think the obvious interpretation is, wow, if you test people, and of all the people you're testing, you have 10% positive or 15% positive or 20% positive. It's just, oh my goodness, there's a lot of COVID out there. But the other interpretation of that is that we know that for every case that's diagnosed, there are other cases that are not. And that if you're at 10% or 15 or 20%, that from a public health perspective to control the outbreak, you're not having enough tests being done. And that you want more tests and a lower positivity rate. That's an indicator that from a public health and controlling the pandemic perspective, you're doing enough tests. And so I guess my first question is that I may misunderstand that epidemiologically, but then the other is, I don't know that that's necessarily widely understood if it is correct.
That actually is correct. And in addition to that, it matters who you're testing. If you're mostly testing symptomatic people who are close contacts who are more likely to be positive, your positivity rate is going to be higher than if you're testing the general population. One of the reasons we didn't choose to use that as a benchmark in our data is just that fluctuation in that test. And one thing that a high positivity rate can mean is that you need to do more testing, or you're only testing people who are going to have the disease. So your positivity rate is going to be higher.
It would require a monumental effort on the part of county and local leaders to continue to test at such a high rate that you pick up a lot of the negative patients that are out there, negative tests that are out there. It'd be a huge effort, but you could find what the positivity rate was, but it would be tough.
Well, just one additional comment, guys. I can say anecdotally that at the hospital, when we went to, because everybody's wanting to have confidence that this really works. When we went to universal masking, our rate of work-related transmission exposure went down to virtually nothing, other than in a lunch room where two people were eating together, which we've talked again and again about. It's those types of moments. And so we are firm believers that that it's when you can't be perfect in a lot of the other things that you're trying to do, that we've seen it with our own eyes, that masks have been very, very helpful.
Thank you, Dr. Shamiya.
Yeah, we certainly agree with that, with our staff doing the volume of testing they're doing and definitely being exposed to COVID positive patients, with the patients wearing masks and our staff wearing masks. I'm not aware of any positive cases in our staff from a work-related exposure.
I just want to say thank you to both of you for bringing up real world examples of staff and community members wearing masks and infection rates going down. Because again, there seems to be a common misconception, I won't say common, a thread in public perception that masks actually make people ill, that they will reduce their O2 sats, they'll pass out, they'll be more likely to get ill. And I think those of us that are in healthcare kind of just take it for granted. We wear masks all the time to keep other people from getting sick and to keep ourselves from getting ill. And if masks were really lethal or increased morbidity, illness, there'd be a lot of nurses and doctors and clinicians and people in healthcare who would be sick. So this seems so obvious to us, but I'm not sure it's always obvious to people out in the community. So I'm glad you shared that real world example of once everyone had to wear a mask all the time. You've seen the likelihood of people becoming ill with COVID go way down. And also, I'm assuming it's implied, and maybe you can clarify, you haven't seen your staff or your colleagues level of illness, rate of illness go up from wearing the masks.
So if I may, I'd like to add one point to that. And again, this is maybe another simple real world example. This comes from the dental side of things. We've gotten a couple of emails over the last day or so about a phenomenon that was referred to as mask mouth, and it's kind of an homage to meth mouth, but it's mask mouth. And supposedly, if people wear masks, they end up with a higher level of either gingivitis, periodontal disease, or tooth decay. And I kind of researched this when I started reading about it because I'd never heard of it myself. And what I found out was that the articles were in the New York Post and several other articles, several sort of social sites. And I looked in the scientific literature and could find nothing about this. And actually, one of my colleagues called up the American Dental Association's scientific affairs group, and there is no scientific information on this. What we suspect is more from a psychological standpoint that this pandemic has changed people's perception about what is necessary and what they can sort of leave behind, and dental care is part of that. And we saw it when the initial closing of the community occurred in April, that there were people who had serious cardiovascular problems that didn't seek care, and dental problems are part of that. So we're starting to see people who should have had their teeth cleaned 2 or 3 months ago, should have had a filling put in, and now they have an abscess tooth that needs to come out. That's actually fairly common. And I guess my editorial plea would be, if you need to have dental care, or if you think you need to, go ahead and go to your general dentist, because they're prepared with all the proper N95 enhanced PPE to take care of you. And it can be done easily.
Thank you for that.
Any other discussions regarding 2020-1? If not, we can go into the next item of business, which is 11, and that is revisiting 220-4, 220-5 with a review and discussion of those regulations. Anybody want to open up the discussion on those items?
So I can just mention briefly that I worked with Mr. Sanders to see if we could possibly include businesses that had kind of brown bagging, as we termed it, that didn't necessarily have a beer or liquor license, but that we could have them also included under the same ordinance with that 10 o'clock curfew, is what this one stems from.
Is anybody prepared to discuss or propose any amendment on that as a board?
I just wanted to say that in Nashville, they're starting today that you have to be seated at a bar. They're not going to allow standing at a bar.
Point of order, I believe we need a motion on the floor to discuss Mr. Sanders. Is that correct?
Yeah, I think a motion is in order at this point if you want to discuss. If I recall, you were going to discuss the 2020-4, and there's also a potential for 2020-5. I don't recall on the agenda offhand whether it's the same or not, but if you're going to discuss 2020-5, you do need a motion to go ahead and discuss it.
I'll make that motion.
I'll second. Dr. Gocher, you're off.
Sorry, I said a motion instead of motion anyway, so you didn't need to hear that. Let's have a specific motion so that can be recorded. Are we talking about reviewing 20-4, or are we talking about introducing 2020-5?
I would make a motion to, I guess, discuss how 20-4 is going, but also to consider at the same time, because I think that the two are so tied together, that to have a discussion of how the new ordinance might replace the old one.
So I think, Dr. Sousa, if we have a general discussion on 04, which we have passed, that we would not need a motion to discuss that because that's part of our agenda. But if we want that discussion to veer into changing things, we should start by having a motion specifically to change things. Mr. Sanders, is that?
I'd agree. The easiest thing to do is simply to move the proposed regulation to pass and then have a discussion. And in that discussion, of course, you can address any perceived shortcomings of 2020-4 as well.
So,
okay.
Dr. Sousa, if you would
make a motion to pass
that amendment for us, or try that
2020-4. Is that what we're gonna?
5.
Okay, so we're going to make a motion to pass 2020-4, but then discuss 2020-5. Is that correct?
I believe
because we don't actually need it to. We don't need to do 2024.
2020-4 has already been enacted.
Correct.
So we can discuss that generally, but if you want to veer into 2020-5, it would be more efficient, really, to have a motion to just go for 2020-5. Need a second, then we can begin discussion.
Okay, how about this? I'll motion to pass 2020-5.
Very good. Second? So we have a motion and a second. Now discussion.
I guess I could just reiterate what I said a few minutes ago, is that this was, I think maybe 2 to 3 weeks ago, when I had brought up that we'd had a number of concerns from people in the public that there's some businesses that while you can bring your own alcohol, there was no, they were not included under the previous 2020-4. And so this would simply close that loophole.
Other discussion, other points of discussion.
Yeah, one of the questions I have, and this is more to Mr. Sanders, some of the public has talked about the fact that we've, picked one area, bars, and a specific percentage, and now we're maybe talking about adding brown bagging. What legal ways are there to include, let's say, even restaurants at our 10 p.m. curfew time for the sale of alcohol? Is it something that is easily done? I've seen some question about that among the public, and I have that question too. And I know we've had some discussion back and forth. This amendment is of one specific area, which is really a small part of our community, very, very small. But a bigger one would be the restaurant industry, and whether or not that's the issue that some have talked about with the students congregating or other people congregating when they move out of a bar, going to a restaurant, that they can continue socializing and congregating.
Well, let me address that question in two parts, Dr. O'Brien. The first part of the question is basically, what is the basis for targeting bars or entities that either sell alcohol or, in the case of the proposed regulation, allow brown bagging? And I believe one of the findings of this board on the last regulation, 2020-4, is that excessive consumption of alcohol leads to a lowering of social inhibition, which leads to increased risk of exposure. That was sort of the idea behind it. If this board finds that a similar dynamic is happening in restaurants, then it is within the board's power to regulate restaurants as well. There's no prohibition against it. It's just this board chose initially to draw a distinction between bars and restaurants. Bars essentially meaning entities that derive more than 50% of their gross revenue from the sale of alcohol, and restaurants being entities that derive more than 50% of their gross revenue from the sale of prepared food.
Well, thank you, Mr. Sanders. Let me just ask a question maybe to staff. Are we seeing any issues coming out of complaints or things that are being found by staff in restaurants based on late hours? Are there gatherings? Are there complaints by other people? Is this an issue? And then the other question is, overall, should we continue down this road in this tact of having a curfew and restriction? Are we seeing anything that tells us that we should continue this at this time overall?
So a couple things. One is in interviewing cases about the UT associated cases, anecdotally, we're being told that the bars on the Strip are definitely ignoring the curfew. We've had a conversation internally about what we can and can't do about that. I've yet to have that conversation with Mr. Sanders. We do have a regulatory authority over restaurants. However, we've been told by the state, who gives us the money to do that, that we cannot use COVID regulation violations as part of a restaurant inspection to go down the road that we normally go down to remove somebody's license. So we can't incorporate this into our usual restaurant inspections. It would be a different avenue that we'd have to go down to do anything to regulate that. I think regulation is, it's a challenge. It's hard to get that information. It's hard to ensure compliance. It really requires, not just our staff, but also cooperation with others like law enforcement for regulations to be effective. So that's one of our challenges. But we have certainly heard anecdotally that bars on the Strip are not all, maybe not all of them, but are not complying with curfew. I don't have any other information from staff. I'm looking at my other staff that are in the room to see if anybody knows anything else.
Yeah, not aware of anything. That's the big thing.
Dr. Buchanan, I have no personal knowledge of this except what we get in our many emails per week. And it looked to me in reading emails regarding this subject that a lot of the bar owners felt like that their business was being diverted to restaurants that were open, say, until midnight or so forth, and turned into de facto bars. However, I don't know that we've heard anything from any independent verification of that. And before we started going after potentially the business plan of restaurants, which typically make over 50% of their money from the sale of food, I would sure like to have some concrete evidence that would say this is definitely a trend, and these restaurants are sliding around the law. My sense is it's probably not happening, or if it is, it's not happening very much. But I have no data to back that up.
That would be difficult data to gather. We again are being told anecdotally that that's what's happening. You heard Chancellor Plowman comment on that regarding student activity. So she certainly agrees with that. When the bar is closed, folks are just moving to a restaurant that's serving alcohol and finishing their evening out there.
I mean, you said something interesting that you're telling us that there are bars in our community who are blatantly, sounds like in the area of the university, not following this. And unfortunately, we've always said it's education. We don't want to do enforcement, but then the question comes down to is what we have, if we have to vote to continue this, is it worth anything, the paper it's printed on or the ones and zeros digitally to continue it? So that's something I think we just need to think about right now.
Dr. O'Brien, I would agree with that. It's kind of a sad comment in a way that what I think we feel is kind of a common sense recommendation, not based really on strictly alcohol consumption, but just getting unmasked people in tight quarters for long periods of time, whatever they're doing, is probably going to generate cases.
Based on Dr. Shamia's data and case counts across the state, if you look at a place where they have had they have a lot of regulation happening in Nashville, and we've seen their case counts go down. But they have uniform support for how they're handling that and how they're handling violators. So.
Yeah, I was going to make that point. I mean, like it or not, they have demonstrated the ability to really get a consistent decline. Their actions seem to have led to a consistent decline in case counts.
Yes, and I'd like to point out that we initiated this regulation based on the White House task force recommendations, because Tennessee and Knoxville in particular was a hot zone, and it was one piece of helping mitigate the very quick rise in cases and hospitalizations. And so for the public who thinks, we just kind of pulled this out of a hat and decided to target bars, and specifically target isn't the word. I mean, it was based on the recommendations and the data that we've gathered and seen in other cities across the state and the nation. It was based on recommendations. And so it's very unfortunate that many bars are trying their darndest to comply, adhere to the regulation, and they feel like they're bearing an unfair brunt of restrictions, and they continue to make these very poignant pleas to us. And I've brought this up before, that we need to consider, do we need to expand the restrictions even without the data, because what we know is looking at the data from other communities in Tennessee and across the nation that that it works and it mitigates people getting ill and impacting the community at large. So I don't think we need to go backwards in terms of throwing the baby out with the bathwater, but fine tuning things perhaps, or expanding those restrictions, even if we don't have data.
You know, I will tell you that
Specific.
in Davidson County, there were some pullbacks that occurred because they have a variety of places that alcohol is served, including on the multiple rider sort of bicycles or pagoda sort of things, the mobile entertainment deals. They've reinstituted those. They're mainly outdoors. That's an example of starting to back away. And I don't know what their numbers were that justified that, except maybe it was a political move. I don't know. And if anybody has any information on that, it'd be nice to find out about it.
Their benchmarks are similar to ours, and they're using data to make those decisions. They have a pretty extensive plan on their website with, they're operating slightly different than we are, in that the health officer is writing the orders and setting those policies in place. So that's how they're operating in Nashville. And that was one of the things with the regulation that we're discussing, 2025. Some of the whereas, Mr. Sanders pointed out, some of the whereas clauses are outdated. They're more than a couple of weeks old. And currently, Knox County, by the White House report, is in a yellow zone, and the recommendation is to limit occupancy of gyms to 25% and close bars until percent positive rates are under 3%. Create outdoor dining opportunities with pedestrian areas. It also recommends limiting social gatherings to 25 or fewer people. We're not really talking about that right now. So that's only one of the things that's kind of outdated, and I could go through the others if you want me to, or we can wait and talk about them later. But that is where we are based on the White House report at this time. This White House report came out on the 30th of August.
Well, based on that, Dr. Buchanan, I would throw out the proposal, not as an amendment, but just as part of this discussion, that we may wish to refine this document to make it contemporary before we pass it.
Again, this is not my thing, but Mr. Sanders, if we could do that, if you want to go ahead and update it, would it just need to be, Mr. Sanders, a friendly amendment to update the pieces that are inaccurate?
Yes, in general, it'd be a friendly amendment, presuming that the mover and the seconder agree that enhances the proposal. Then with the approval of the chair, it can become a friendly amendment.
Yeah, I'd be okay with that. And I know it's just a matter of finding the more up-to-date numbers.
Well, actually, I have them, so.
Oh, you got them?
Yeah.
Okay.
And the person who's second, I would agree and state that we could remove old whereases that do not apply, and then update the one that we just talked about as needed. And this is at least a starting point for us to at least work on this brown bagging group. But we may need to work also on others. The curfew may be on the alcohol and not on the ability to be open for business. And we may want to talk about that aspect. So where somebody would still have people there, but they're serving food as their primary thing and not having alcohol served, may be a way to preclude this movement from a bar to a restaurant. So I don't know if that's something that can be done, but what we have now is a good start.
Well, Dr. O'Brien, in terms, this is very good as part of this discussion, but in terms of what we have on the floor, this would strictly be that brown bag section, and it may be in a way more data is needed. I remain concerned about altering the restaurants business model. I would hope that the restaurants are not exploiting their business model as some of the bar owners assume is happening. I don't know if that's true or not, but I'd sure like some information on that before we made a decision.
And I agree. I think we just stick to what we have in front of us, but bringing up for discussion in this open forum,
yeah.
If we have issues and they are identified, we may have to go that route.
Right.
So, if I may, I'm going to ask Catherine to pull up the regulation as written 2020-5. So if, so on this first page, the whereas that says, as of, okay, so we have to, the first, sorry, I missed one of the whereases. So as of August, the first whereas, as of July 14th, that would need to be changed to as of August 30th. The White House, the rest remains true. So just the date changes. And then the second one, again, changes to whereas as of August 30th. And we need to change red zone to yellow. And then both new cases, reported both new cases above 10 to 100 per 100,000, and diagnostic testing between 5 and 10%. That's the current White House task force recommendation. Obviously, the whereas, and whereas 9.1 and the next one, Tennessee Department of Health still continues to see us as above the threshold of acceptable transmission within the community. That remains true. The next whereas regarding Dr. Burks' statement, that can stay, of course, it is her statement. She was talking about the state of Tennessee being a red state, and the state is still considered red overall. I'm looking at you.
Oh, what happened to that? I'm sorry.
Can you look real quick?
Yeah.
Okay. I think the state continues to be red overall, so that would certainly, I didn't see a reason to remove that one. The next whereas, as of July 28th, I'm just not sure that one's not accurate at this time. So I recommend that that whereas of July 28th since May 25th, that we just delete that whereas. And then if you go on over to the second page, the third whereas on the page, no, it's not the, no, sorry, yes, it is the third. So whereas as of July 28th, the foregoing is blah, 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 effect pursuant to executive order number 59 it is now, it's not 50. And that the date of that order is not June 29th. I'd have to look at that for sure, but it's order 59 now. So I guess my friendly amendment would be to update the dates, remove the whereas. That is just no longer accurate on the first page, and update the whereas is to be accurate based on the current White House report and the most current executive orders.
So if that friendly amendment is okay with the author and seconder of the amendment, the chair would exercise the ability to have that friendly amendment included. Any discussion about that? Are we good with that?
Those are all fine with me.
Okay. Mr.
I think just to clear, I think just to clarify, there's a few that say that it would replace 2020-3 and that would just have to be updated as well.
Right. Mr. Sanders, anything parliamentary that we have done incorrectly in changing that friendly amendment?
I think we're on track so far.
Okay. Okay. So now we have a slightly altered motion, And a second. Further discussion.
Mr. Sanders, could you please clarify some definitions? Actually, first is Dr. O'Brien said, how many establishments were we actually talking about here in Knox County, specifically to the brown bag thing? That's for anyone, sorry.
Yeah.
I have no idea. I'm going to have to step away and deal with something. I'll still be available roughly. So I'll be right back.
I don't know that we know, Mayor. It's probably 2, 3, 4. It's a very small number. And this is based on input from people that were in those places, predominantly employees.
Yeah, that's what I'm thinking too, is it's probably half a dozen at most, right? And then Mr. Sanders, on the wording here, in paragraph 3, section D, can you please clarify the word establishment means any restaurant, club, or any other business of any kind, unless it markets prepared food to customers or patrons and derives at least 50% of its gross revenue from the sale of prepared food.
You're under D, as in Delta?
Yes, sir. 3D is the definition of establishment.
Yeah. And so what basically we've done here is, and I apologize, I had a nice email document pulled up at one point that sort of set this out more succinctly. But your original regulation 2020-4 simply defined a bar as an entity which sold alcoholic beverages and derived more than half of their income from that sale. And so when we were rewriting this to expand it, the first thing I did was realize that alcoholic beverage is defined under statute. That doesn't include beer. And that's why we now have alcoholic beverage and beer defined in sections A and C. But then what we wanted to do was say what a bar actually was, to include different ideas, either the selling of alcoholic beverages or the allowing of customers to a brown bag, to paraphrase. But what this board did not want to do was to capture restaurants, as we conventionally think of restaurants within this definition. So a bar is any establishment. Well, what is an establishment? Under this definition, under Part D as in dog of the proposed regulation, establishment is any of these businesses, however they may define themselves, unless it markets prepared food to customers or patrons and derives at least 50% of its gross revenue from the sale of prepared food. So a restaurant, as we conventionally think of one, is not an establishment under this regulation, and therefore, as proposed regulation, and therefore could not be a bar under the definition of this proposed regulation. And the regulation in paragraph 4 only applies to bars. So does that clarify it for you?
It's a little confusing.
It is, you're right.
And my fear is that this could bleed into other businesses, possibly.
And obviously it's up to the board to decide how to apply this and whether to apply this, and whether to add or subtract anything from those definitions. This is a proposed language that I assisted one of the members of drawing up, but that's all it is. Obviously, I don't have any say in whether you all adopt it or in what form.
So in terms of the operational definition of brown bagging for purposes of this. I think we have to be very careful in crafting this because there's a lot of restaurants that will have a court charge for bringing in your own wine to a restaurant. We want to avoid having that included in here purposely or inadvertently.
Right, Dr. Gochert. I believe those restaurants are not included because they're not, they are excluded under the definition of establishment. They do derive more than 50% of their income from the sale of prepared food. And therefore, they are not an establishment. If they're not an establishment under the definition of this regulation, they're not a bar under the definition of this regulation. So regardless of corkage charges, the regulation would not apply to them.
So, Dr. Gochert,
your thoughts on where this might go off the rails or problems? I really value your input on this.
I'm sorry, who's that for? Was that for me, sir?
I would like your input, if you would, on, concerns where this might go in unintended places. I share those concerns, and I was just wondering.
Sure.
Your input on this.
Well, I think the first thing to remember is when, as Dr. Buchanan has stated in the past, we have no way of auditing anyone's books. So it's pretty easy if we're using the definition of gross revenue from the sale of food or from alcohol for a brown bag to just say, if they normally would have a cover charge or whatever, to just up their price of food significantly to fit under the definition of a restaurant as opposed to a bar. As this is written, this is extremely confusing, and that's nothing on you, Mr. Sanders. It's just a confusing situation, and my office will get inundated with calls about what exactly this means and who it applies to and all those sort of things. And frankly, we're going to have a lot of trouble answering on those because I'm still confused even after Mr. Sanders' explanation there. And then I would worry too that, I don't think this would happen in Knox County, but if we are not very specific on who this applies to and the language isn't very clear, that many other businesses that I know we've taken care here, and I appreciate that what the board has done with restaurants, but we might capture other businesses inadvertently that, do some sort of brown bagging or allow people to drink alcohol in their premises.
And I would second that. There'll be a lot of staff education on our end to help our staff understand and be able to help businesses and others understand who needs to do what. So one thought, if the board wants to continue down this road and do that, would be, or in the future, it might be helpful, Mr. Sanders, to talk with our environmental staff as they work in this world all the time and understand the language better than I do, as far as how to define bars and restaurants and things like that. So that's something that would be a resource. That's not talking to me, that's talking to my staff. So it's not a board member to board member deliberating anything at all. It's my staff who have some expertise that I don't have, supporting this board to craft regulations that people can more easily follow.
Sure, Dr. Buchanan, I'll obviously be glad to. A couple of things I should note is one is I pulled when I was assisting the member who wanted this to begin with, I pulled a lot of this terminology straight from the statutes, which already regulate the sale of alcoholic beverages. But secondly, I think one thing we just need to be clear on, if this board aims a regulation straight at businesses which engage in protected First Amendment activity, this regulation will have no value and it won't have a lawsuit on our hands. So you cannot specifically target a regulation at a particular business that engages in First Amendment free expression.
appreciate that comment. I understand it, and I agree with that, but there are businesses that have crafted their charters or their business plans around what is generally considered to be the law. And we do have First Amendment considerations to think about here. Thoughts from the committee or from the board, I mean.
Dr. Gosher, I have a question and a comment. I just want to, or also Mr. Sanders, for 2020-4, is it, I mean, are we forced based on an expiration to take some sort of action today? I can't remember the expiration, or is no action an option tonight? Meaning things will be status quo if we take no action.
Mr. Sanders, can you comment on the expiration on that or the review period on that? Please unmute. Sorry.
I'm not sure I have a current copy of 2020-4, so you all, I believe, extended it at your last meeting, but I'm not sure I have a copy of that extension at my fingertips to see how long it lasted.
I'm looking at the 2020-4, and at our, let's see, today's September 2nd. So it was set to expire August 20th, and I can't do math in my head. So that was that last, and then on the 19th, we decided to extend it another 2 weeks. And was the 19th last week?
Which would be this week. Today's expiration.
Okay. So today's is the expiration date of 2020-4.
Okay, thank you. And then my comment was, and I've kind of just been really just listening and absorbing through this. And I mean, I think this really gets back in a broader sense to our intent. And we have to think about what are we really trying to accomplish? And we've said that at the beginning of this discussion. It's that, and we've said it multiple times, it's that in situations where the 5 core actions are inherently less likely to be followed as it gets later into the evening, as inhibitions are lessened. And so, you know, what is the best way to try to accomplish that? The second thing we've mentioned in this conversation is about enforcement. And I don't really think it is, I mean, ideally we would craft something that is, you know, there are things that you can craft that are inherently probably more or less enforceable based on the nature of the restriction. And so that should be kept in mind. But at the end of the day, though, I don't want our thought process. I mean, this is from a public health standpoint. That is our role, to be impacted by just what, you know, whether it is or is not, or could or could not be enforced. I'm still troubled by the idea that Knox County has, you know, what one portion of the county may need is maybe different than what another portion. But I think the underlying theme across this entire conversation is the desire to be fair. And meaning that we are trying to not have an impact on, you know, when ultimately at the end of the day, it's about the intent. It's about what are we trying to accomplish? And we don't want to be inconsistent in how we do that. And so, you know, Dr. Drake mentioned that's what you ask, well, why on earth are they doing, you can't stand, you got to sit? Well, it's because of understanding that type of environment. You just realize that if you have to be seated, it inherently puts a different type of environment than if everybody's gathered standing around. That is, I'm not saying that's the right thing to do, but that's based on somebody understanding what really happens. And then, you know, the question about, I mean, a few meetings ago, we went on and on about beer versus liquor. And, you know, maybe there is something to that when you start talking about what we're really trying to accomplish. Now, I don't know that we're going to be able to sort through all of those things tonight. And that's why I started with, is any action specifically warranted? I certainly understand from a fairness standpoint, the brown bag piece. I mean, I think that is key. I don't know how impactful that will be. I understand the concerns about that it may be create some degree of confusion. And so, you know, one action would be to simply, if we're not sure, than just because UT's got some rising numbers, no question. The community has inflected plateau, and I do sense is from a diagnosed cases going up. I don't think it's time to pull this back, but I do think it's time to think about what is the way to best accomplish the intent.
So Dr. Shamiya, just a point here, and that is we have in a way two different roles, if you want to think about that, as a Board of Health by statute. One of these is we can work strictly in an advisory role, and we could say we advise various brown bag institutions not to do this or to practice the 5 core actions, or we can do it by regulation. And regulation is sometimes, as best we try to craft these things, it's a blunt instrument, and we don't want that instrument to be inadvertently used. So it's perfectly okay to step back, at least in my opinion, back into an advisory role if that's what you would like to do in any of these matters.
Well, I would argue that, not argue, but I would state that I think our advisory role is a potentially blunt instrument as well in these types of situations. So I'm not necessarily implying that my suggestion is that we back away. I'm just saying that if we're going to continue to be, I mean, it's clear that we've talked about this. We've danced around restaurants past 10 p.m. Dr. Hurt has brought that up on more than one occasion. And so it really is about what is the best way across the board to target the issue. And Mayor Jacobs, you've mentioned that in prior meetings. You know, what's the real issue here? What are we trying to accomplish? And so, you know, the problem is, I mean, this is a tough one. And so I would be at peace with in this, knowing that the brown bag piece is likely just as much of a potential issue as the others, and that it is in the spirit of fairness. Adding that in, I would be fine with that, but I don't want to lose sight as we go forward in future meetings about, is there a better way to approach this fundamentally than the way we've right now? I'm sorry I don't have the answer. I mean, don't raise an issue if you don't have the answer, but I'm at least sensing that, that we should think about that.
I'd like to point out, it's my understanding, and Dr. Souza, correct me if I'm incorrect, I'm mistaken, but the whole brown bagging issue has literally come as a request from employees at these institutions. It wasn't on our radar, but we didn't think about it until we kept getting consistent email feedback from people who work in these institutions who say, look, we need you all to help us out. We don't feel safe. People are coming in and they're not observing the 5 core actions. Customers are coming in and we employees don't feel safe. So that's how, if I remember correctly, that's how this came to our attention. And this was the intention behind it, as you said, Dr. Shamiya, is fairness and equity. Because we know that alcohol use, especially the more people drink, is going to inhibit their common sense. And that's just human nature. That's not a judgment. That's just a fact. And so we know people are less likely to observe those 5 core actions. And so, but this is community. This whole conversation and what we're trying to achieve here is community driven. So there may be some confusion for some people in the community, but there are, I think, just as many people who are going to say, thank you. You heard us and you're trying to make this an equitable issue, because again, our intention is to keep people healthy. And one solution would be also is just all alcohol sales after 10 stops, whether you're a bar or a restaurant or brown bagging or whatever. And just as an idea, again, to mitigate the increased risk of exposure with certain, that we know is linked to certain activities. Dr. Souza, am I correct in understanding the history of how this whole brown bagging and
Yeah, Dr. Hurt, you're absolutely right. It basically started with numerous emails for probably about 3 to 4 weeks in a row that we got. And then I brought it up, I guess maybe 2 or 3 weeks ago, and Mr. Sanders was willing to work on it to try and figure out how to close that loophole, because there was numerous folks in our community that were really concerned about their risk exposure at their places of work.
That's what I thought. I also have a question for Mr. Sanders. You mentioned if we propose anything that would in any way infringe specific, I thought you were saying to this regulation that would infringe on First Amendment rights. Of course, that's not our intention, our goal, our just not. We're very keenly aware of that. But I'm wondering if you could maybe elaborate. I don't really understand how this particular regulation, as we've conceived it and developed it, could even touch on First Amendment rights. So
Sure.
Yeah.
Sure, Dr. Hurd, it doesn't. And that was crafted that way. It's crafted to apply to various entities that meet certain criteria. But if there was what I perceived in the earlier comments, a call to simplify this, to make it not so circuitous in its logic. And, for instance, if we wanted to regulate veterinary clinics, you could say, we're regulating veterinary clinics, period, end of discussion. And I just saw that because I saw Dr. Sousa's face there. But, obviously what we're talking about is we're talking about gentlemen's clubs, so-called gentlemen's clubs here. And as one of the entities, although there are others, I should note, as far as I understand, there are lodges, private clubs, et cetera, that charge a cover charge or a membership fee for people to come in and drink their own alcohol. But the call that you all got, the emails you all got, were from employees of gentlemen's clubs. And if you say we're going to say any business that's regulated, say as an adult entertainment establishment in Knox County is hereby closed, period, they're going to be in court saying you're discriminating against them on the basis of the First Amendment, because they have a First Amendment right of freedom of expression to engage in their activities. So you can't, you need to capture all entities that engage in the behavior that you're trying to stop. If the behavior you're trying to stop is the excessive consumption of alcohol in a particular time frame, then you need to be even-handed about it, not just cover the ones that some members of society disapprove of. Is that clear?
Yes, thank you for clarifying that. So we are trying to fine tune and do a surgical approach, is what I'm understanding you to say, not the blunt approach of just broad swaths, and hence this deliberation about the brown bagging terminology, perhaps. That's my understanding of what you're saying. Why would it be specific?
Well, I think the mission I was given was that you all had a regulation applied to entities that sold alcohol, and people would cluster and drink alcohol possibly to excessive amounts. And somebody pointed out to you that there were these entities out there where people were doing the exact same behavior, except that they weren't paying for their alcohol there, they were bringing it in. And the question was, can we design a regulation that captures those entities also? And the answer is yeah, it's in front of you now. Now, frankly, it is circuitous in its logic. I was trying to tack something onto a regulation you had already written, and perhaps the best way to do it is to throw that one in the trash and try again next week with some cleaner language. But I think that what you have in front of you will do what I just said, which is capture those entities which allow people to come on premises and drink, but are not restaurants in the conventional way we think of restaurants, that being a place that derives most of its income from prepared food. And incidentally, prepared food is a term of legal meaning. It's different from selling bags of pretzels. Prepared foods means you have a kitchen and you're cooking it. And so you can't just have you can't park a food truck outside and say we're selling prepared food. We, the business, are selling prepared food. Now, another business may be selling prepared food out there, but and you certainly can't do it by selling bags of pretzels. So there's some thought did go into that phrase.
Thank you.
So, Mr. Sanders, can I just ask Dr. Gocher? So, bottom line, isn't it true that what we have before us meets the needs that we've gotten from the public and also allows us to vote on something that we could then continue? If we don't vote tonight on this, we vote this down and nothing else is put forward, we will have no regulation after midnight tonight. Is that correct?
Well, there's different matters before us in a way, because we have 2004, or excuse me, 2020-4, which is set to expire. We have 2025, which expands 2024. So we're actually debating 2025 right now.
Correct. And I just want to be clear, everybody understands, if we, for some reason, did not come to a determination on this one, and we didn't go back to number 4 and do anything, that we end up with nothing. So I just want that to be kind of clear.
So if the sense of the board is to study this more, you can make somebody can interject a ability to postpone this definitely, if I'm correct from a parliamentary standpoint, which would allow us to study this 2005 a little bit more and return to it next week. You can postpone it definitely to any period that you want, but I would suggest next week if we're meeting weekly. And then we can go back and revisit with a motion and a second 2004, and that would be to extend what we have. Mr. Sanders, am I doing that correctly?
The problem is, I think what you're essentially asking for is a motion to table the motion.
Right. Postpone.
But the motion to table, as I understand it, has to be dealt with before the end of the meeting. That is, whatever you tabled in order to bring up a new motion has to be dealt with at the end of the meeting. You have a motion on before you that has been seconded. What I would do, I believe, is simply hold a vote on it. If it fails, it fails. You can bring it up at another meeting.
Right. I'm
sorry.
But we do have to address if it is voted down at this meeting to be revisited, if you choose, or not, you would need to make some action on 2004 or let it expire. And it would be the will of the board to do that, however you'd like to proceed. All right, so I just want to make sure that the board members are clear from a standpoint of motions and votes as to what we are doing.
So Dr. Gocher, I'm clear, first of all, and secondly, if Mr. Sanders, I mean, it's clear that this was a thoughtful, as complicated as it is, this was a thoughtful attempt at getting the wording right. And so I think it depends on, would we be delaying, because I feel like there's going to be some action. We've done a friendly amendment. We would have to, but if it's delay to conceptually think about it more, that's a different thing than delay to get the wording right. And I guess my sense is that Mr. Sanders has already really been thoughtful and deliberate in trying to get the wording right. And so, Mayor Jacobs, I know you've expressed concern that it's still maybe somewhat inherently confusing, but I don't know how much, if it's I guess the question is, what would be the point of the delay? Because if it's to get the wording better, and we don't think we're going to do that, then it may be reasonable just to go ahead and vote as we've, at the end of this discussion. And so I don't know, Mr. Sanders, if you have thoughts, or Mayor Jacobs, if you have thoughts about that, but I don't want to delay and look at the same exact document if it was all about the wording.
if Mayor Jacobs doesn't mind, let me just interject a couple of things. One, I think under parliamentary procedure, another option is to withdraw the motion. That would take, at this point, since it's been seconded, it would take a majority vote to permit a withdrawal of the motion, but you can do it. Secondly, if it is the will of this board, I can assist the membership, individual members, with coming up with some less confusing language, hopefully. I think the language that is present before you accomplishes the purpose that I was asked to accomplish, with the addenda that there are still some issues out there that I communicated with some or all of you earlier regarding the specific wording. There's still some tweaks that are needed. So I could integrate those into a new motion and probably clarify this so it's easier to read, set out definitions of each type of entity and say, this is what this applies, this new regulation is going to apply to. That it can be done, it can certainly be done better from a wording perspective, even if the intent of it is the same and the effect of it is the same.
One point of discussion, there have been some actions that we have taken that had an acute need. For example, the mask mandate back in July 1. This is one that if you look at the number of people that are impacted, it's relatively small, but the potential for this to be either, number one, misconstrued, or number two, have a deluge of questions and comments and such, both to the mayor's office and to the health department, I think is likely. And I think taking a week to study this and work it in more detail would have more benefit than passing it tonight. I don't think that there would be a significant change in the public health of our community by holding off a week and getting it a little finer tuned. Thoughts about that?
It is a holiday weekend.
So from our perspective, I read this, but I didn't pay attention to when it was set to go into effect. There's a couple things from our side. Again, these changes in regulation, as you know, part of what our team does is help with enforcement and help with compliance. So I was looking to see. So when is it set to go? So you intended it to go into effect? Okay, so the date's wrong, or maybe I have the wrong one. What was the date you intended for it to go into effect? I'm sorry, I couldn't find that. Mr. Sanders? I think
Sorry, the dates were probably still on there from when I thought this was going to be considered last week. So it obviously goes into effect whenever the board says it goes into effect, and y'all can make that decision, and we can make the change on the draft. But I'm not sure how better to answer that. It goes into effect whenever you decide it goes into effect.
Okay. So again, from our perspective, one, I think I would like the opportunity to chat with my team members to understand even the potential for regulating this. I'm not even sure these establishments or establishments that we have a regulatory relationship with. I honestly just don't know. And so, and if the board does choose to table this or withdraw it or whatever, you know, I know my staff would be willing to help with some of the language so that it's a little easier to understand. And not, you know, so there's the legal language, but then there's the language that's used in the industry that people understand. And so they're not always the same. So that would be something that if that's what the board decides to do, we could do that. But I do also think it's reasonable to find out if these are establishments that we have a regulatory relationship with or not, because if they don't have a food permit, we don't have a regulatory relationship with them.
Thank you for those comments. Any other comments? We have a motion and a second before us for 2020-5. Any further discussion on that? And the chair would accept any additional information, or Dr. Sousa, if you had a wish to either withdraw or table the measure as per our discussions, that would be acceptable at this point.
Excuse me, Dr. Goetcher, only withdraw. Table would mean you'd need to take it up before the end of this meeting.
Before the, I'm sorry. Yeah, okay. So it would be a withdrawal motion.
So if there's enough concern of the board, I don't mind withdrawing it from tonight. I very much appreciate Mr. Sanders' efforts to put this into language that I can hopefully understand, which is legalese. But you know, if it's something that we would want to revisit in the future, if we can find wording that's more clear and more prescriptive, then I'm okay withdrawing it from this evening.
And I'll withdraw my second for legal reasons for Mr. Sanders.
Mr. Sanders, does this require any other action on the part of the board in terms of a vote, or are we okay?
I think you need to get approval of a majority of the members.
Okay, so you've heard a motion to withdraw 2020-5. Any further discussion on that motion to withdraw? If not,
Question about so once we do this, if there is action on the one that's expiring, then we do that next, Mr. Sanders. Is
that would come next.
Okay, Dr. Goetcher, thank you.
Yep. So any other discussion on the motion to withdraw 2020-5? Hearing none, Dr. Buchanan, would you give us a roll call on that, please?
Sure. Dr. Drake.
Yes.
And we are voting on a yes is a motion to withdraw, just for clarity.
Correct. Dr. Goetcher.
Yes.
Dr. Hurt.
Yes.
Mayor Jacobs.
Yes.
Dr. O'Brien.
Yes.
Dr. Shamia.
Yes.
Dr. Souza.
Yes.
Ms. Wagner.
Yes.
All members voting yes.
So we have voted to withdraw the action on 2020-5, and we stand available to reconsider 2020-4 if the board would like.
I'll make a motion to extend 2020-4 for another 2 weeks.
We have a motion. Is there a second on the motion?
Second.
Second.
We have a motion and a second to extend 2020-4 for a 2-week period. Any discussion on the motion?
I want to just bring up one thing more for staff based on what they've said. You know, our job is to look out for the public health. And we have established this, but we're having issues, it sounds like, in the community. Is there any recommendation from staff that instead of a continuation of a curfew, that more education be allocated, or an advisory recommendation to this segment of our populace versus continuing down this road with our curfew? Just wondering if there are any thoughts from staff.
None of the staff that do that work are on this call. So, and I don't know. So I'm happy to ask them. I will state that the rules and regulations for restaurants, bars, and nightclubs under the Tennessee Pledge are the recommendations are, other than a curfew, are pretty good. They limit some alcohol and limit how you consume alcohol and those kind of things. But I certainly can check with my staff regarding if there's something different that they think would be more helpful. Absolutely.
That's what I was getting at. I was wondering if under the Tennessee Pledge, we may accomplish things with more education versus continuing a curfew, which sounds like is being abridged by a number of establishments exactly where we want them to follow it. So, you know, having a regulation that people aren't following is, it doesn't make a lot of sense long-term. It's not that I'm against what we're doing, but I just have concerns that we are putting something out there and we have people not listening and not being willing to follow. And we have nobody at this point, you know, enforcing it.
And I'll check with my staff, but I think the majority of places are complying. Excuse me, but I'd have to check with my staff on that.
And Dr. O'Brien, I'm not sure I totally followed in that. I mean, it seems like those two things are not mutually exclusive. I mean, we can provide that education, whether there's a curfew or whether we're the Tennessee Pledge, and you know, ultimately if you want to talk about the strip and whatnot, I mean, the longer term play is to try to keep the college, for example, going as long as possible. And so, you know, some of the education may be what ultimately makes the most longer term economic sense, and not just, you know, over a holiday weekend, for example. But I know that's tough. I know that's tough to do.
It is, and you know, again, we're trying to balance out education with an enforceable regulation, and the exact area we're interested in seems to be having issues with that. So, I mean, I have no issue with us continuing this short term and to look at it, but if we get to a point where the area that is of most interest to us, i.e. the university area, we have that as the area where they're not following it, while out in the county, you know, in the suburbs, et cetera, those places are closing at 10, they're following it, they're not our issue. So we just need to kind of watch that, and staff and others, codes enforcement, to give us information of what's going on actually in the community.
Are we extending it for 2 weeks or 1 week?
That's the motion that's on the floor, Ms. Drake, or Dr. Drake, is for 2 weeks. Other discussion? Hearing none, are we prepared to vote? Is there any thought for altering that, or are we prepared to vote on extension for a 2-week period? Hearing none, I guess we're prepared to vote. Dr. Buchanan, would you do a roll call for extension of 2020-4 for a 2-week period?
See if y'all are paying attention. Ms. Wagner?
Yes.
Souza?
Sneaky, yes.
Dr. Shamia?
Yes.
Dr. O'Brien?
Yes.
Mayor Jacobs?
No.
Dr. Hurd?
Yes.
See if I'm paying attention too. Dr. Gocher?
Yes.
And Dr. Drake?
No.
Okay. Motion passes 2 noes and 6 yeses. Sorry.
I guess I would point out, if we have information that comes up that we may wish to change this per what Dr. O'Brien was talking about in terms of education, this can always be revisited next week and changed if we need to. Any other discussion on 2024, 2025? If not, we can move to other business as the sort of the last thing. Any other business? One point that I think was brought up, or maybe we talked to Mr. Sanders about, was how we conduct the public forum. And Mr. Sanders, if you want to kind of go over a little bit about what the county commission does and what the rules fall on us, and then how we can change those rules if we need to.
Sure. Can you hear me? My screen keeps freezing up. I'm not sure whether I'm being heard audibly or not.
Yep.
Okay. As long as you can hear me, I'll not worry about my screen then. the county commission holds public, basically the county commission's rules say that they will have public forum at every meeting. And they have public forum both at the beginning of their meeting and at the end of their meeting if there's anybody who wants to have it then. That is, they don't guarantee everybody a slot at the beginning of the meeting. They allow some people to speak at the beginning, and then anybody who doesn't speak at the beginning can speak at the end. And actually, I think county commission also allows for them to speak during the meeting specific agenda items. Although I'm not sure that's in their rules, so that's just a matter of convention for them. But if you all want to change that, you can write your own rules. And
Mr. Sanders, I think your screen froze as well as your voice. Are you back with us?
no, not yet.
We can hear you at this point.
Okay, well, good. My computer's showing that my speaker's not working, but just again, as long as you can hear me, just somebody wave at me or something if you can't hear me.
You're doing okay.
And yes, okay. Anyway, I am working with one of the members at developing a set of rules that we decided weren't ready for prime time tonight, but might be ready next week. They're basically an adoption of a large number of the county commission rules with the county commission parts taken out essentially. And they do have a provision in these proposed rules do have a provision in them for how to conduct public forum. There's a public forum aspect to it, but it's not every week as the draft proposal exists right now. Obviously, that's up to your debate whether you want to have it every week or not. If you adopt a new set of rules,
so
you can have it
under other business. I felt that we should bring this up to at least have some generalized discussion to help maybe guide Mr. Sanders, and then maybe during our next one or even two deliberations, come up with some final ideas. And you know, the points that I had discussed with Mr. Sanders, I'm sure others have as well. We need to look at the length of time at the beginning of the meeting, whether we would have a time at the end of the meeting, how much time would be allotted per speaker, whether it would be done by phone, by Zoom, a lot of technical details. But the main thing I think is the time slot. Right now, County Commission says 5 minutes, we're going at 3. They have a period of time which is open-ended at the end of the meeting. We have elected not to do that. And I want to make sure that if we elect to not do anything, that we stay uniform with County Commission. If we elect to set up our own rules, we can. But we should start thinking about those parameters. So I open that for general discussion to think about and maybe guide Mr. Sanders a little bit. Thoughts from the board?
I'm the one who has worked with Mr. Sanders, and I've already taken the rules for the board or the commission, and he and I are working to amend them with a 30-minute once a month or greater. In other words, if we go back to every 3 months, it's going to be at that meeting every 3 months, but at least once a month, a 30-minute preceding the meeting period, 3-minute periods for each speaker, no matter what and it mentions about electronic versus in person, those are all allowed. And then the rest of the rules are housekeeping. So we were close to getting those ready for tonight, but not enough to show everybody. But I think hopefully that will be able to be pushed to everybody to be seen in the next few days. And then we can have discussion to see if that will be to everybody's liking. But it would basically be a once a month or greater. So if the normal time is every 3 months, we would have it then. But at least once a month, we're going to have a public forum.
Thank you, Dr. O'Brien. I would like to have some discussion on the frequency of the public forum, because County Commission, you know, for example, does this at every meeting. Should we, in the interest of seeking opinion and transparency, do this at every meeting? Are there logistical problems in doing this with every meeting? And Mayor Jacobs can maybe help us, or Dr. Buchanan can help us with that thought process. But you know, in the interest of being completely open as we can to the county citizens, every time might work better, but it might be a logistic nightmare. I don't know the answer to that. Thoughts?
Mayor, I think you're muted.
Yeah, talk about logistic nightmares. Dr. Kocher, to answer your question, like tonight was fine. Really, we do, we require some staff in the building to stay open for folks that don't have Zoom. But, you all were able to accommodate those people, and I think we're able to do that pretty quickly. So, we can do it. So I wouldn't worry too much about the logistics. Dr. Buchanan, I don't know on your end how you feel about it, but as I said, it puts a little more strain on our IT people, but I would not, it would be a big lift to then have anything at the end of the meeting. I mean, if we could do it at the start of 5 p.m. and get it out of the way so that our IT people and other folks can go, that would be helpful, but we could certainly do it.
So again, this is just food for thought as we bring this up as a definite agenda item at the next meeting. But in the interest of transparency, it makes our meetings a little bit longer, but in a way that input, it's helpful to the public, and I think sometimes helpful to us. I think, by and large, we had very reasonable discussion, some very passionate, but we had very reasonable discussion about a lot of different issues. And some of the things are things that we have seen on emails, excuse me, some of them are new. So, for example, the problem in the library that I had never thought about, nobody ever mentioned that before. That was really great input, and so if we had that, make our meetings a little bit longer, but if we had it even weekly for a while, it may be very useful. And I think it would certainly lend an air of more transparency to our deliberations. That's just one person's thought. There's no vote needed on that, just things to think about for next week, maybe.
Dr. Kocher, I do think if we were to go in that direction, it's going to be important that the time frame is, then if people get the weekly opportunity, and then I think we want to make sure that is a time limited piece exercise.
Absolutely.
And then I think that's all. Thank you.
These are things that we can work on. This is the purpose for kind of letting this sort of bench cure, I guess would be a term. Just think about what we're talking about, and we can deliberate, and we can work with Mr. Sanders and Dr. O'Brien if he's spearheading this, and come up with things that will work for everybody. But just food for thought tonight.
And I do have just thinking about the document that Dr. O'Brien that you're preparing or working with Mr. Sanders. Do these type of documents also outline the process by which those speakers are chosen, or is that generally not part of these types of documents?
I can perhaps start off by mentioning that choosing public forum speakers makes me queasy. That is, again, we're talking about First Amendment expression, albeit in a different context at this point, but the number one rule of governmental entities when discussing First Amendment expression is you cannot discriminate based on viewpoint. Right. So you can't pick winners and losers in terms of who you want to hear from. You basically need to open it up to all comers. Now you can open it. There's nothing to keep you from saying the first 10 people to sign up. That's okay. But you can't say the first people, everybody who's in favor of a proposition, nobody who's opposed. So I'm not sure. I just want to be clear on that.
So there is a method to being compliant in that regard. You have to have a system that's then specifically followed, even if it's not outlined in the document.
Yes. Yeah, you should have a system. Typically, those are accomplished I'm not as familiar with the county commission, honestly, as I am with the school board. The school board, they have a number you call into and you get on the list. I think it's probably similar for the county commission. I believe for these public fora, the Mayor Jacobs' office has handled that and his able staff people. And they'd simply get on the list. Also, when you're in person, usually there's an opportunity to simply approach the dais before the meeting and ask to be added to the list.
Okay.
Yeah, Dr. Shamia, for this public forum tonight, basically we opened yesterday. We had a set time period that I had released on social media that people could call in my office and sign up for a public forum. When we did our first public forum, because it was the first one and we had overwhelming response, the board had only dedicated 1 hour, 30 minutes. We did choose some folks. We tried to make it as even as we possibly could based upon their subject matter. But yeah, for this one and going forward, it's just going to be basically first come, first serve, but there will be a time frame which they have to sign up during which.
Okay, very good. Thank you.
So things to think about, and I think we should look at this next week in detail and hopefully come up with some regulations that will work for our board. Any other business to come before the board this evening? Long meeting, fruitful meeting, I think. I think we talked a lot, got a lot of information, talked about a lot of different topics. Any other thing to come before? Anything out there just sort of searing you? You need to get it out. If not, I'll accept a motion for adjournment.
I move that we adjourn.
Second.
Great. So we'll see everybody same time, same community TV channel next week then. How's that? Good night, everybody. Thank you.